And for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, and liberty and justice for all. Okay. Thank you all. Please be seated. If we can have the roll call, please. Well, that will be in a minute. Hang on, we lost our secretaries.
Dr. Bart. Dr. Berkowitz. Here. Dr. Berry. Dr. Bombard.
Bombard here.
Dr. Cooper.
Here.
Dr. Cushman.
Cushman here.
Dr. Daly.
Daly here.
Dr. Doynow.
Here.
Dr. Gomez. Dr. Isaacs.
Isaacs present.
Dr. Kugler.
Kugler here.
Dr. Lynch. Dr. Markowitz. Dr. Maynard. Dr. Murphy.
Let the record show Dr. Murphy just had to step out for a moment, and she is here, and she will count towards quorum.
Thank you. Dr. Olson.
Olson here.
Dr. Raybridge.
Raybridge here.
Dr. Talbot. Dr. Walters.
Walters here.
Dr. Wysolinsky. Dr. Winslow.
Winslow here.
Oren Barzilay. Aidan O'Connor. Mark Philippi. Marianne Portoro. Mike McAvoy. Steve Kroll. John Washko.
Present.
We have quorum.
Excellent, thank you. I do want to thank all of you for coming. I know some of you traveled a considerable distance to be here, but it is important that we do have a quorum at every meeting. Do want to mention a few things. We will have a psychiatrist as one of our members shortly, being vetted. We've had 3 surgeons who are interested in having the STAC appointment to the SEMAC, so hopefully we'll have a surgeon member pretty soon as well, which will help. Next, I want to thank Dr. Lou Marshall, who's been a friend and colleague for years. I think it was 25 years as Med Standards Chair, for being here today. And Lou, if you have anything you'd want to say?
Goodbye. No, I'm kidding. I'm not going anywhere, but thank you very much, and thank you for the opportunity. I started teaching at the Academy in 1992, and in 97 joined the Fire Department of New York as a medical director, at which time I served on STAC, actually. That's where I started. In 2003, I joined SEMAC. And in 2006, as I said before, stepped out of the room for coffee and became chair of Med Standards. So be careful when you leave the room. But it has been a true honor. I think in 2006, all 18 regions had 18 different sets of protocols. And we spent hours and hours discussing minutia. And we talked about having a single set of statewide ALS protocols for the past 2 decades, and I would like to thank everyone around this table for educating me and tolerating me. And I think that we are there. I think we have, the medicine is the same. There are some operational differences, but I think we've gotten to where we need to be. And I think as we move forward, looking at integrating EMS more within the whole healthcare system, and being part of healthcare in the United States, I think, is critical for our patients and our providers both. So thank you for everything that you've educated me on, because I've learned from everybody in the room, and not just those at the center table, but from around the room entirely. It's been a great experience, and I'm not going anywhere. So thank you, Don. Don won't let me go.
Thank you, Lou. You're now eligible for the SEMAC retirement check showing up in your mail maybe sometime in the next 20 years. I'd also like to welcome Dr. Raybridge, who is now the new chair for Med Standards.
Thank you. I have very big shoes to fill there, and I guess it's too late to not step out for coffee, but thank you.
Okay, just a few other announcements. Just an update on the state medical director. It's still in progress. I think when it does come through, many of you will be very happy with the job description, and hopefully people from this audience will apply. A few other things. Al Lewis, if you're here, if you wanted to talk about EMS as essential services, it's been one of my goals since I've been chair, and it looks like that is slowly moving forward, hopefully. Al, are you here?
Good morning, or good afternoon now, isn't it? It's close. So thank you, Dr. Dwayne. I don't have a crystal ball, but I can almost assure you that we will have something like essential services or essential services passed by the end of this session. There's so many people interested, and we have a team together. Nice Vera and Onion and so many others believe this should happen. We endorse it and embrace it, but the devil's in the details. NISAC has been carrying legislation in support of this, and we've been really attached at the hip with NISAC to try to get something passed that the towns, villages will embrace. I think there's real concern as to who's paying for what and how it's going to be administrated. So I believe after all the time we've discussed essential services and the people that are at the table, that I believe rational people will end up with essential services by the end of this year. So that's my comments. Thank you, Dr. Duino.
Thank you, Al. Okay, moving along, we need approval of there wasn't any minutes from December, but the previous meeting. Anybody want to make a motion for? Okay, thank you, Dr. Cooper. Second, anybody? Thanks, Mark. Anybody against? Let's do it that way. I assume everybody is in favor. So the previous meeting's minutes have been approved. Ryan, if you want to go ahead with the Bureau staff report.
Thank you very much. So moving forward quickly through the top stuff so we can get to the bottom stuff. Just related to operations, we've seen our EMS self-assessment is out there, so that happens right before full service inspections related to agencies being able to find out a little bit, be able to provide some more information, but then also for the district chiefs while they're there for their full service inspections to be able to provide some additional feedback and best practices. We actually had a great conversation during the quality committee yesterday about how we can work together on that one and sharing some quality initiatives. So the goal would be possibly for the quality committee to come up with a one-page flyer or something similar that brings them to their web page, and the district chiefs to have some speaking points related to that. So at the end of a full service inspection that they can share some of that information, share some of the work that's being done at these committees and out, because often it is agencies that are looking for how do I do better, but I don't know where to find the information. And so we're going to work together, see if there's synergy there to help share that information and move that forward, with the first step being with the quality committee and the work that they're doing. On the administration side, we continue to process contracts and payments. Just a reminder to all of our, our agencies or contracts that are out there, please, you have your funding, use it, and do great things within the EMS community. We know that we are underspent often, and we are trying to work with that. We had a great meeting on Monday about that with the program agencies to talk about other initiatives or other ways that funding can be used that maybe isn't being used at this current time. And so hopefully we'll see what happens with that front. On the education front, first starting with the pilot program. So we have 5 pilot programs that are out there right now: the EMS Academy program, the internship program, the leadership program, and recruitment and retention. So we have all these pilot programs that are out there. However, unfortunately, even though most of these pilot programs came from ideas from around this room, from outside this room, from the EMS community, many of them aren't being used. So we have money, we have allocations to them. We're trying to enhance the EMS community. We developed these pilot programs based on the feedback that we got that they're wanted, and now we're not seeing buy-in. So we'd love to see more of these pilot programs actually have more engagement to them, or if they're not what we need, well, then let's close them down. But I don't think that's the case. I think there's a lot of opportunity here. One of the ideas that actually came up yesterday was related to the EMS Academy. So we put it out there, instead of just limiting having academy-style programs and paying additional funds for it, we put it out that any course sponsor can teach one academy-style class per year at the higher reimbursement rate. The suggestion that came up this week, well, up here, was that's great, but it hasn't happened that often. What can we do to make that better? Well, when in those discussions, when we did the original pilot program for an academy, it was actually with the military as well. We had a very set deadline. It was you had to start the date by this date, you had to end it by that date, and that really brought buy-in to the point where the civilian side of that program had more applicants than it did spots. And so the suggestion was to possibly do one or two initiatives throughout the year that set a clear date and have this body and the Bureau and things advertise those specific academy-style programs to see if we can get back to that waiting list, get back to that interest level where people otherwise, where there was literally a waiting list to get into programs. We sold out. We had 650 spots, and 650 spots were filled. With about 400 in military and about 250 that were non-military. So we're going to take a look at that to see if that can help. That's just one of the examples. We're pushing out the leadership program throughout the state. We again got some additional asks on that one of how do we help do it. So now we have program staff, bureau staff who are literally facilitating those, and I think we have 3 or 4 dates or 3 or 4 programs. We will come to any part of the state. Please tell us if you're looking for it. We'd be happy to bring it. It's a 2-day course. It was developed for New York State. It's a great program, and it will actually also work as a train-the-trainer program as well. In the education world, we had 2 major backlogs recently, CME and reciprocity. For CME, we're happy to say that it has continued to get caught up, and we're in a good place. It really didn't fall back. It didn't fall too far behind, but it fell behind what we normally are processing things at. In addition to that, there was a reciprocity backlog. Reciprocity had a significant backlog. It was over 3 months for us to get that initial review of it. We were very transparent about it. We're very transparent about all of our times right now. They are all listed on our website. You can go, and we're going to update it most likely once a month unless there's a significant change. And it will show you what our normal averaging time is and what our current processing time is. We were over 3 months. That really wasn't acceptable for us as a bureau. We came in, we powwowed, we figured out kind of why that was occurring, why it was taking as long as it was. We redid some of our processes. We added some additional support into those processes. We are now down to 2 to 3 weeks for processing reciprocity. So we're really excited to see that change. We want people to come to New York. We want them to come become providers, but we also want to make sure that they're verified and processed in an appropriate way to make sure they are the right provider for New York State. So both of those processes, thank you to all the people on the outside who helped in giving feedback, as well as every team member who helped bring those processing times down. During those processing times, we also had the opportunity to look at some of our online portals, and we recognized that there are some things that we could do better at. One of the things was when you hit submit, it wasn't necessarily telling you anything. It just brought you to a great blank screen, and then you had a best guess if you actually came to us or not. If you went and checked your email, it showed that the email sent you a copy of your application, so you knew that we got it. But we were able to do better, so we looked at even some simple stuff. And now on those screens, it will say, yep, it was submitted. Here's your submitted number. Here's validation. And by the way, can you please also take this particular email address off of your spam or put it in something so that if we send you a question, it doesn't end up in spam. Because I can't tell you how many times CME applications or reciprocity will send, hey, we need additional information, like you can't upload your national registry card 6 times and have it count for your ACLS, your PALS, and your CPR card. Yes, that's a real example. But when we email them, it goes to their spam, and then that creates all sorts of problems. So we're all learning together as technology comes. We are happy to say we do not accept anything anymore, for the most part, related to applications in our office by paper. It all comes in through the portal. It all is in one centralized place, and we appreciate everybody who is using those processes along the way. 3.5, the standards are out. Any EMS platform, any EPCR platform can move to 3.5 as of next Tuesday, but they have to move to 3.5 by July 1st. So by July 1st, you must be on 3.5. After 3.5, the Bureau will start to, we'll give a grace period, but we will start to enforce that you have to be submitting your PCRs and you have to meet the standard. Just a reminder, it is an agency-level responsibility to submit your patient care reports. It is not a vendor responsibility. If you have a vendor who is not submitting, that's not the answer that the Bureau will take as an answer. That's between the agency and the vendor. As far as we're concerned, it is up to that agency to submit their things. And this is important, particularly for everybody around this table. It's not only about data getting to the Bureau, but it's about data getting to the hospital, data getting to the patient side, data on what it is that you provided to that patient. So it's really important that we get there. So again, July 1st is the full transition, but it could happen before if you or your EPCR platform decide so. STAC just met last week, really progressive meeting. Happy to see things moving forward there, particularly on the system side. We're seeing more and more hospitals go for trauma status. We have over 50 trauma centers now in New York State. The biggest one lately is becoming a level 3 trauma center in different regions, and happy to see those things move forward. On EMS for Children, we now have an emergency department, Always Ready for Children program that supports pediatric readiness. There's a federal program that we've brought into the state. We also have the EMSC survey for EMS agencies that will be deployed in May. That will go out. You'll get an email about it. We encourage you to respond if you are able to or have time. And our next EMSC Advisory Council meeting will be here on May 6th. So if you'd like to join us on May 6th for EMS, we will be here. Vital Signs. So Vital Signs is coming to Rochester. We just closed with a record. Just closed our call for speakers with a record number of responses. Thank you to everybody who respond. We also just had a site visit there last week. I got to see the convention center and the areas that we'll be in, and test the local walkable food, which was very, very good. In case anybody's wondering if that's part of what brings you there. It was a great time. I really got to see a lot of what Rochester has to offer. In full disclosure, I've not seen a lot of Rochester in the past, and I'm really excited to be there. Jeremy did bring me there, went out with Jeremy in the past, and we saw not only the city, but outside of it. And for those of you who don't know, it is the home of the first Wegmans. And if that doesn't mean anything to you, then you need to come to Vital Signs just to go to your local Wegmans supermarket. I said to Jeremy, where are we going for dinner? He said, well, have you ever been here before? No. So, all right, what do you recommend? Well, then we're going to Wegmans. I was like, what's Wegmans? He said, it's a supermarket. I said, you're taking me to a supermarket for dinner? I walked in and said, oh, it was impressive. And now every day I walk into my supermarket and realize it's not as impressive. So I encourage you to come, if nothing else, to see what the biggest Wegmans looks like out there. But we are really excited about the conference. We also have a new track in addition to everything else this year. We have a special operations and rescue track, again, from the feedback from people in the past. So bringing in some different things that we haven't brought in before, giving a different track. And Rochester really gives us a convention center that can adapt to that. It has a lot of space, has a lot of breakout rooms and things to be able to offer more tracks than what we've been able to offer in the past, purely often because of space limitations. So our EMS Memorial is Wednesday, May 22nd. That's Wednesday, May 22nd. I know many are used to seeing it on Tuesdays. We do have to move sometimes by a day, just based on availability and what's going on at the plaza and other things. We have 8 honorees that will be going onto the wall this year. And hopefully, saying all goes as planned, we're hoping to have the new memorial at this year's memorial. So for those of you who aren't aware, our tree has filled up, unfortunately. And the number of leaves that we know will be needed in the future exceeds what the space is available there. So this has been something that's been in the making for several years now. We've had a committee from SEMSCO who's helped us in this planning, and saying all goes well and everything else, and it sounds like it is, we will have a new wall this year. It will have a smaller tree in the middle and then names on the side that will get engraved, and so you'll be able to do a tracing of the name of the honoree that goes on. We're really excited about that, and then there'll be some additional upgrades actually in the next year or two, even after the new memorial goes on. On some other news, blood regulations are moving forward. We had a great working group on that one, so we're working on now putting those into the legal part of the regulatory reform on that one. A couple more working groups probably to complete that, and then we'll start seeing that out for public comment and then in front of this group. Community paramedicine advisory group is being developed as well that's related to our community paramedicine regulation that passed last year. Has an advisory group who will help us working on draft regulations related to community paramedicine. The county assistance grant is moving forward, hoping to have that out hopefully by May or June of this month. That's $5 million that's allocated for up to 10 counties to receive up to $500,000 each to help support EMS development within their county. And the OASIS program. This is a program we've had for the past couple of years. It's been an outreach program to help with mental health and well-being and reaching out to them. Jenny Solomon, who I don't know if she's here or not. Stand up, Jenny, for a second. So this has been Jenny's passion for the past couple of years, and I just want to say thank you for all the work that she's done. She's literally been traveling around the state delivering this course to hundreds of providers through the OASIS grant, and it's been a great program. It is due to sunset in March. It will still be available online even after that. But I just want to say thank you for everything that you've done over the past couple of years and for bringing this great content out there. And also want to thank OASIS for financially supporting this initiative to be able to train our providers as well. From a regulation update, our education regulations were out for public comment. Thank you for all those who took the time to respond. That closed yesterday. We'll finish up the parts that we need to do now. If there's no substantive changes that need to occur, hopefully that will come in front of us in May at the SEMSCO meeting to approve as regulations and then be adopted shortly after that. The equipment regs continue to go through the regulatory process. We are hoping to see them out in public comment period at the May meeting. Time will tell. There's a lot obviously going on in a number of different fashions right now. Rural Health Task Force continues to meet. The goal there is to have a advisory paper or white paper out by April 1st. Again, working through those processes too, but the Rural Health Ambulance Task Force has really been doing phenomenal work in bringing new ideas and innovation onto paper for suggestions for our legislative bodies. So thank you to everybody who's a member of that committee, that task force, that working group. Obviously, there's Part V that is out right now related to the budget that has a lot of things in there related for EMS. We are doing a lot of informational sessions. We encourage everybody to join on an informational session. They're for council members, non-council members, REMSCO members, REMAC members. Lots of great information. So if you go to Part V, there's some great work there. There's some documents that we've already shared with this group that are public documents, two one-pagers two-pagers that are out there, one being about Part V, and we encourage you to do that, and then come to the meetings. You'll hear a little bit more about it and have an opportunity to ask questions. As well as that, there's also the state EMS task force is moving forward. Probably the biggest question, there is a two-pager on the state EMS task force that's a public record as well that we're happy to share. Probably one of the biggest questions that we get are the zones the same as districts from last year? The answer is no. The state EMS task force and what you saw in districts last year are two separate things. So last year in the budget, state EMS task force passed. That is legislatively in there to help New York prepare for future disasters, prepare for future response. Part of that preparation is making sure there's resources and assets throughout the state. And there are two big things that come with that. One is making sure that it's throughout the state. Those are your zones. There's 5 zones throughout the state, separated by the economic development areas, but there's 2 economic development areas to 1 zone. And then there's a really big public-private partnership that will occur, and that will enable upwards of 60 ambulances that are currently in your agencies. It is, they will be contracted agencies that will be paid for readiness to have an ambulance ready should a disaster occur. And at the time that disaster occurred, they'd be activated and then paid for the time that they're deployed. There's not going to be a specific probably ambulance out there that says, State EMS ambulance, task force ambulance. It would be that these are, think of whatever your local agency is that would be out there. But at the time of disaster, one of those ambulances would be dedicated to responding. And that will allow us in groups of 5, so 25 BLS under contract, 25 ALS under contract, 10 critical care, because we know our national partners do not provide critical care services under deployments. So 10 critical care ambulances will all be subcontracted and be able to be out there. And so we're really excited about this initiative. We're excited to see this move forward. The zones will separate so that if there is an incident that's happening in Zone 1, the resources from Zone 1 won't be pulled. We'd pull from Zone 2 or Zone 3 or Zone 4, so that we're not pulling equipment that's locally affected. There's a bunch of specialty equipment that will also be purchased and allocated throughout the state, as well as there will be preparedness staff that will be state employees that will be part of the task force. And then through, again, conversations here, there were some concerns. Well, how many state staff are you going to hire? And those are paramedics, and we need paramedics in the field. And it was through some of the conversations here, and this is why we love having these 2 days to talk about things, of we are now also going to work on creating a program to train additional paramedics for every paramedic that we look to hire, paramedic position that we look to hire. So if we're going to hire 80 paramedics, we're going to look for a program over the next 2 years to sponsor 80 EMTs to go to paramedic school. And we're going to see if we can make that diversion so that we're never going down in number just by starting to further support our disaster response system, but rather build on it and build around the state and add more providers. And maybe that will become a program that even exceeds and goes beyond that, even past the number of people that we provide, so that it's a constant stream and a constant positive thing out there and feeding kind of the future of EMS. Last but not least, 2 things. One, I would like to thank Dr. Marshall, who's sitting here, who I will say during medical standards this morning had smiled more than I've ever seen you smile before, but from a table just a couple feet back. I have only been here 6 years. You've clearly been here a lot longer, but your wisdom, your guidance, your professionalism has been truly amazing to watch. You have truly been a leader of this council for many, many years in many different hats. I'm sorry that it was because you walked out of the room at the wrong time to get coffee. But I want to thank you for all your service, for everything you've done for EMS, for everything you've done for the department, the many commissioners that you've served under, as well as the Bureau. Thank you for everything that you've done. And the second person I would like to thank is immediate past chair, Mark Philippi, who is coming towards the end of his period as well. And again, we are a little bit more aligned. You were slightly longer than I've been here, but have gone through a lot together, and just want to say thank you for everything that you've done as chair, everything that you've advanced, everything that you were very passionate about calling me off and on to make sure that it got done and moved forward and stayed on track. Your work as chair was very much noticed. It is the reason why we continue to advance in EMS. And thank you for all your passion, dedication, and everything that you've done for the Bureau, the department, and the commissioner. With that, that's the end of my report.
Okay, thank you, Ryan. Why don't we move now to med standards? Is there a number of action items? Jeff?
Thank you. Yes, Med Standards has a number of items to bring forward. First is the collaborative ALS protocol update, which does include the alternative medication formulary and hospice care protocols that were discussed as well. So we want to take that as a group. There was a seconded motion brought forward from Med Standards to approve the collaborative ALS protocols.
Do we have any discussion? We have a motion to approve. Second motion, Dr. Kruger. Okay. If we could have a roll call vote, that would be great. Can you bring it up?
Peter?
Right.
Dr. Berkowitz,
Berkowitz, yes.
Dr. Bombard,
Bombard, yes.
Dr. Cooper,
Yes.
Dr. Cushman,
Cushman, yes.
Dr. Daly,
Daly, yes.
Dr. Doino,
Yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Dr. Kugler, yes.
Dr. Markowitz, Dr. Murphy, Dr. Olson,
Olson, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Walters,
Walters, yes.
and Dr. Winslow.
Winslow, yes.
Motion passes.
Okay, thank you. Moving on.
Moving on, then the next item was the New York City protocol changes, which included 3 protocols. They were the anaphylaxis severe allergic reaction protocol, which was updated basically with language for clarification as to what constitutes anaphylaxis, addition of ipratropium to the albuterol for wheezing. The next protocol was emergency childbirth, where there was a change that moved left the nuchal cord considerations into at the CFR level. There was some data presented from New York City regarding the number of times that's happened and the arrival of CFR there prior to BLS or ALS units, as well as comment that it was moved to the EMT level in the national scope of practice, but that was discussed with some considerations for local changes. And then the third protocol was the vaccine administration policy. So that has come forward as a second in motion to approve for the New York City protocols.
Any discussion? Dr. Daly?
So this actually became a little bit of a discussion for some of us This became a little bit of a discussion for some of us between meetings. You know, one of the things about childbirth is it's less about what you can do on your own and more about just what you're presented with. I think awareness for the CFR of a nuchal cord, the ability to call for help taking care of that nuchal cord is all extremely reasonable to do. However, this is not within the scope of training for the CFR. I'm not really sure it makes sense for us to move it into a protocol for a CFR when CFR is actually is legislated to a certain number of hours, and this therefore extends that core state curriculum and moves it past where the state BLS protocols are. I would suggest that perhaps this is something that if it has become an issue in New York City, that they train their CFRs about it, that we still continue to believe that moving below the stop line after talking to medical control is something that's reasonable, and that orientation awareness and call for help is probably the best thing rather than making this a CFR standing order, which I'm not really sure makes sense.
So we currently provide education and training to our CFR members, and just recognizing, not treating it, I don't agree with. I mean, this is a time critical in terms of oxygenation to the newborn, and again, if they're arriving before BLS and ALS, this is a very time-sensitive procedure. So they are getting training and education on it, and the national standards do allow for areas that feel need to allow for this training, you know, for certain skill sets that are not part of national standards that had been moved up to EMT or higher. So we do have some data showing that CFR does arrive on scene before BLS and ALS, and so we strongly encourage for this protocol for our CFRs.
Any other discussion? Okay, do we have yeah, we're discussing the entire group, so Anybody have any discussion, anything else on this?
So the only thing that I'll just bring up on the other side is the vaccine administration one. So there's, legal is looking at this one for two aspects. One, taking off the executive order. So there's a lot of agencies in New York City that are under the community paramedicine program. They can give a vaccine. There are two vaccines that they can give, and there's the ability for them to give that without a patient-specific order because there's specific wording in there related to that. And the other component, so I guess the question on the vaccine one is, how can it occur, can it occur, and does it need kind of any additional waivers, such as the ability to give a non-patient specific order, as well as just from the conversations from before, from Dr. Cushman in the last meeting and things like that, of is this something that is a protocol, that should be a protocol, because this wouldn't be an emergency situation, or is this something that should be separate?
So this is the scope of practice as we discussed at the earlier meeting. It is a medication by FDA and currently had been a practice during emergency situations. So, and again, it's just being consistent with what we've done in the past, and we are protocolizing it. We're not a community paramedicine program, so I don't see how that's deviating in terms of kind of standard of care in terms of what we've been doing in our regions. So I'm not sure why it has to fall under community paramedicine.
So no, what I was saying is under community paramedicine, they can give a vaccine. So today, and there's a lot of agencies in New York City that would fall into that one. Related to this, what you're pulling out is the executive order, which is the part that said, that allowed EMS providers to give a vaccine. There's been some back and forth in this in why, can an EMS provider give a vaccine, can they not? I bring up the conversation of the protocol from before just because of, what we were talking about with Dr. Cushman and things of that nature of, I can't imagine that we're going to a 911 call saying, I know what you need. You need this vaccine right now. So the question becomes, does that become part of a protocol, or is this something separate within, that framework? Is it under this body? Again, I will also say, me personally, I support EMS providers giving vaccines. I think it's a skill we can do. We proved it during COVID over and over again. But the legalities and some of the other fronts behind it is where the questions fall. So not the question of, is this a good idea? This is an excellent idea. This is a way to move forward, to advance and everything else, but it's the framework, and is it, the right location for it?
Understood. Again, it's a life-saving medication without the politics on it, and so, but thank you.
Any other discussion before we move forward? Okay, well, we'll need to get a vote then.
Dr. Berkowitz,
Berkowitz, yes.
Dr. Bombard,
Bombard, yes.
Dr. Cooper,
Yes.
Dr. Cushman,
Cushman, yes.
Dr. Daly,
Daly, yes.
Dr. Doynow,
Yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Kugler, yes.
Dr. Markowitz, Dr. Murphy, Dr. Olson,
Olson, no.
Dr. Raybridge,
Raybridge, yes.
Dr. Walters,
Walters, yes.
and Dr. Winslow.
Winslow, yes.
Motion passes.
Okay, thank you. Moving along, Dr. Raybridge.
Thank you. The next item was the BLS protocols, which comes forward as a seconded motion to approve as well.
Any discussion? Okay, if we can have a roll call vote again.
Dr. Berkowitz,
Berkowitz, yes.
Dr. Bombard,
Bombard, yes.
Dr. Cooper,
Yes.
Dr. Cushman,
Cushman, yes.
Dr. Daly,
Daly, yes.
Dr. Doynow,
Yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Kugler, yes.
Dr. Markowitz, Dr. Murphy, Dr. Olson,
Olson, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Walters,
Walters, yes.
and Dr. Winslow.
Winslow, yes.
Motion passes.
Thank you. Dr. Raybridge?
Okay, next item, Med Standards received a recommendation from Training and Education regarding the sunsetting of the EMTCC level. That was sent last meeting to SEMSCO, but as there was no SEMAC or Med Standards, it was referred back to those committees. Med Standards brings forth the seconded motion to affirm Training and Ed's recommendation regarding the sunsetting of the CC level.
Dr. Raybridge, can you read this for us?
My eyesight is
My
not that
binoculars are
good,
not
but
here. Let's see if we can bring it up on somebody's computer to be able to read.
The bullet points that you see in front of you are that commensurate with the need to eventually sunset the CC. All expired EMT-CCs can continue to refresh at the AEMT level via established processes indefinitely. The final CC to paramedic bridge shall commence in April 2026. The ALS collaborative protocols will remove the EMT-CC level of care on July 1, 2027. All currently certified EMT-CCs shall expire on July 1st, 2027. Their cards will expire, not them. And they will automatically be recertified as AEMTs at that time for the duration of their certification cycle. And then all EPCR platforms in use shall reflect the previously certified CCs by their new level on July 1, 2027.
Thank you, Dr. McAvoy. Any discussion? Okay, seeing none, can we have another roll call vote, please?
Dr. Berkowitz,
Yes.
Dr. Bombard,
No.
Dr. Cooper,
Yes.
Dr. Cushman,
Cushman, yes.
Dr. Daly,
Daly, yes.
Dr. Doynow,
Yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Kugler, yes.
Dr. Markowitz, Dr. Murphy, Dr. Olson,
Olson, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Walters,
Walters, yes.
Dr. Winslow.
Winslow, yes.
Motion passes.
Okay, thank you. Dr. Raybridge?
Thank you. Yes, so finally, there was a discussion regarding a community paramedicine protocol from Westchester on antibiotic usage, which led to a broader discussion of whether those should be protocols or guidelines or how to approach those. And there was a motion that was seconded and approved regarding that. The motion read, the CEMAC believes that the administration of medications using a route within the practitioner's scope of practice is within the practice parameters of a community paramedic program and may be administered with direct medical oversight and a patient-specific order for such medication.
Any discussion? Dr. Cushman?
Cushman, I'm going to actually speak against my motion. So it's not because I don't believe that. It's not because I don't believe the motion, and it's you can look at it one of two ways, either my haste or my passion, probably a little bit of both, to advance all this. What I'm reminded of since making that motion is that there are a lot of different aspects to some of the words in that motion. What community paramedicine is, what medical direction and oversight of a community paramedicine program is, what scope of practice is related to community paramedicine, where that exists today, where it may exist in 6 months from now. I'm concerned, and again, I will be voting against this motion, not because I don't believe it, but because I am frankly worried that doing so and endorsing may be premature when we have not quite fleshed out the details of what the framework of the administration of these programs, very much to the comment that Director Greenberg just brought up, which is, where do vaccines sit? Do they sit in protocol? Do they not? Again, in self-flogging, my haste of making a motion to try to move forward things needs more robust discussion as to where that lives and what is the structure in which this body and ultimately the Bureau guides things that are either non-patient specific orders or community paramedicine or MIH or whatever else it happens to be. I heard in Director Greenberg's address apparently a working group related to community paramedicine. I frankly was not aware of that, but it seems like that's where these conversations need to happen. If there are some individual, and I'm throwing myself on the proverbial sword here, whatever I can do to be a part of that, members of Med Standards and SEMAC, then we'll make it happen. But that's why I'm not sure that the motion will. It is in the end an opinion. I am worried of the negative consequences of that opinion in light of the evolving structure in which community paramedicine exists.
I would agree with Dr. Cushman's comments, and I think that was the discussion, was where does this go and where does it belong, and those kind of things. So I understand why you might take that approach with your motion.
So I still like the motion as it stands, partly because obviously this comes out of a pilot program request out of the Westchester region. I do believe in supporting our regions and the agencies that want to innovate within EMS. And I think that it's an important part of how we advance EMS in the state. And also, I'm not even aware of many pilots that have been rejected, but that goes here, there, without that. The other part of the discussion I think was relevant is that this is happening every day, that paramedics are delivering medications by physician order when they're doing interfacility transport, and it's no different than that. And so I would ask, we should also be sure that if we are going to deny this, that we should make that clear regarding that, because those medications that are administered are being done by a patient-specific order.
Sorry,
Jeremy.
John, I appreciate that. In the end, the motion as it was made, frankly, whether it exists or not, does not advance the Scarsdale program, right? If one wanted to make a motion related to a pilot program there, then that's fine. But the motion in and of itself does not effectuate the Scarsdale program moving forward. It's not specific to that program. It's not specific to a pilot. It's not specific to anything else related to that. That's my point. So if you want to make it a pilot, then that's a different motion as I would see it.
Dr. Cooper had a comment, and then Dr. Winslow.
I just raised my voice to support Dr. Cushman's objection to this motion at the present time.
Winslow. Yeah, so this was hotly debated, and I think the vote was 7 for, 3 against, and 3 abstained, so it was certainly not anything of a universal support. I think there's a lot of questions here. I think we can support the development of community paramedicine without making a formal motion here at this time, because this is brand new. A lot of people here have a lot of questions about it. I just think the timing is not right.
Any other discussion? So,
Right, it has to either be sent back, approved, not approved, tabled, but you can't just leave it out there, is what you're saying.
no, but it can be voted down.
You could vote it down.
It's up for a vote. I assume it's up for a vote.
The motion is on the floor right now.
Right.
If someone else wants to make a motion to amend, that's allowed.
Yes, but the motion can be voted down.
Right,
if-
yes.
if-
Doesn't go down. Another comment?
Yeah, so I'll make a motion to amend it. Do I need to make a vote on that, or can I do that?
Well, let's just be clear, there's, Dr. Cushman's motion, I think this is a separate issue from your Scarsdale pilot program. That, as far as I know, is in effect, we weren't voting on your pilot Scarsdale program. Is that
Right.
correct?
So I would like to, so then we can vote on this, and then I will make a separate motion.
Okay. Can we read the motion one more time there?
Just a point of order that I think is important to the council members to understand. The legal folks and I have been sidebarring on the side. As you know, 3018 is a very new law. That's what established community paramedicine demonstration programs. And what we're noticing is it's not clear in that, in the language the way it's written now, that this body has authority over community paramedicine protocols. Caveat to that, I think they should, but that's not the way it's written right now. Right now, it requires that the programs currently in existence continue to operate in the things they were approved to do under EO4, and that a advisory body is brought together to build out regulations, which may include authorizing this body to set the standards. But those don't exist today. And so the only thing permitted at this very time is the continuance of the programs as they are today, until such time as those regulations are promulgated.
So if I'm understanding what you're saying, Scarsdale being able to give antibiotics would not be approved by the department.
I'll chime in there for a second. This body working on community paramedicine things, regardless of what it is, just community paramedicine things, is not something that this body would be working on today. That is part of what we saw, and I think we saw community paramedicine come in last year's legislation, but it was also part of the governor's budget. Well, it was also part of the governor's budget to expand the roles and responsibilities of this body, and part of that, I think, aligned with what was proposed. Interestingly enough, community paramedicine didn't get in with the governor's budget, but got in legislation after that. They kind of worked hand in hand, so it flowed nicely, but now's the time where kind of those additional responsibilities, not just community paramedicine, but non-emergency, critical care, things that we spoke about at Med Standards as well, possibly become the additional responsibilities of this body to work on and to expand and to do great things, and to not only, on the ground, but in the air as well. As we know that, there's a lot of critical care resources and things that happen way above our heads, literally, at times. So, I think those are kind of the front from that one. If the antibiotic program that you're looking to pilot is not a community paramedicine program, but is part of, a low acuity emergency response or something of that nature, that's a different story, that's a different vote, that's something under this responsibility. If it's part of a community paramedicine program strictly, then it's not part of this.
So let's make sure I understand and the group understands. If we as a group decide to let Scarsdale go ahead with their pilot program, they could do so as a non-community paramedicine program.
Possibly.
That's part of the discussion over here, that's going to take a little bit of time to figure out. it requires evaluation of several different law sets, and it's not something that can be made on the spot while this discussion is happening. So it would need to be reviewed to determine that.
Just to be clear what the program is, so, because there's some people who weren't at the earlier meeting. So basically, any administration would be essentially associated with a physician encounter, usually via telehealth. These are patient-specific orders, as Jeremy mentioned before, and these are these would be not scheduled visits, which is a big part of some of the traditional CP work. These are kind of lower acuity, unscheduled visits. But clearly the line between what is CP and what's a low acuity, unscheduled visit is very murky. But that's one of the reasons why we should allow pilot programs. Here, they have an invested medical director, agency leadership, and a REMAC who believe this will benefit the population. I think that there's value in doing that. Whichever way we navigate it, I'm just trying to be an advocate for the Westchester region and for innovation.
Okay, let's do this. Let's vote on the motion that's up on the screen, and then we can return to what we're going to do with the program. Dr. Cooper.
How we proceed is obviously up to the chair, but I heard Mr. Gizzura's remarks to suggest that the motion was out of order. Am I wrong?
Dr. Winslow.
I think the chair could move to table this until we get guidance from our legal advisors if we're allowed to make this or not. I certainly think support of community paramedicine is great, but I cannot restate it enough. I do not think this timing is right for this body to make this motion.
Dr. Olson.
Dan Olson. This was brought forth this morning as a protocol. And I've heard pilot program terminology entered into the foray. In the past, when we looked at CPAP for EMTs, and we looked at iGel, and we looked at other pilots or demonstration projects, they were brought forth in a concise, this is what we're looking at, this is what we expect to see, this is what we expect to find. This looks like a protocol. And I don't know if there's enough background data to support or warrant this, but I'm very leery in this present time endorsing anything that looks the way this does. My 2 cents.
I think if I can, I think those are two separate discussions we've kind of merged into one, which is the protocol, the Scarsdale protocol, and then the motion. So regarding your comment about the motion being out of order, the motion simply says that SEMAC believes something. It doesn't, I don't know that that's out of order. I think what that means functionally is something that could be discussed, but that is the motion that is currently on the floor.
Yeah, I'm aware of that. I simply asked the chair for a ruling on that.
At this point, I think that it's there. I'm not sure tabling specifically this motion is going to assist us. Sort of reading the group, I have a feeling that it's going to get voted down, and probably will then end up going back to the group for something in the future. After we vote on this, and we need to discuss the Scarsdale issue, I would say we go ahead and do a roll call vote on this motion, and from there decide where we're going with Scarsdale. So if we could have a roll call vote, that would be great, unless there's more discussion. Okay.
Dr. Berkowitz?
Yes.
Dr. Bombard?
Bombard, yes.
Dr. Cooper?
No.
Dr. Cushman?
Cushman, no.
Dr. Daly?
Daley, no.
Dr. Doynow,
No.
Dr. Isaacs,
Isaacs, no.
Dr. Kugler,
Kugler, yes.
Dr. Markowitz, Dr. Murphy, Dr. Olson,
Olson, no.
Dr. Raybridge,
Raybridge, no.
Dr. Walters,
Walters, no.
and Dr. Winslow.
Winslow, no.
The motion does not carry.
Okay, let's now move on to the Scarsdale issue. And Dr. Berkowitz, if you want to give us a little more detail, and then we'll need to discuss it with the department as to whether this can actually
Right.
go to.
So the pilot program that was approved by the Westchester SEMAC was, as mentioned, is acute unscheduled, low acuity. There's a murky line between what is CP and what is this, but it's not scheduled. It's not scheduled antibiotic infusions for sure. It's not the intent of the program. With support from the agency, the region, their medical director, and the hospitals, and clear evidence of benefit to the patients. I know this is disruptive, but that's part of kind of innovation and moving things forward. So I apologize for all the time that this is taking today. But the motion I would like is to approve, with the description of the program that I've given, to approve this pilot program within the Westchester region so Scarsdale can use these antibiotics. All of them have, like I said, I described the program enough. So that is what I'm trying to advocate for.
Okay, now a little bit of a discussion from the department. Is this something they can legally do, or is it something that you need to discuss and perhaps have an idea before the end of the meeting, or is it something that unfortunately would end up being tabled until the next meeting, which is 3 months from now?
So I think keeping in mind that protocols don't become final until the commissioner signs off on them, and part of that review would include having DLA review all of the protocols for these specific questions with a brief to the commissioner before he signs off. Therefore, I think there's still a moment in time where this, if this was to pass this body, still has the ability to undergo a legal review in the department prior to becoming absolute final sign-off by the commissioner. So I think it's going to take a bit of a dissection of where this is. Is it community paramedicine, or is it initial care and treatment under the current definition of emergency medical services?
And this would be a pilot program that the department and the commissioner would need to approve. That's what they're asking for. Not actually a protocol change, but a pilot program.
I would say it would depend where it would fall. So at this point, if it lands in the community paramedicine bucket, then the current law says that programs are allowed to continue operating as approved May 14th, which would mean a pilot program would be expanding their current operation. With that was how they were allowed to continue operating until such time as the advisory panel is put together that has to contain very specific people spelled out in the law, and then answers the specific questions through the development or promulgation of regulation, which may include, and probably would be recommended to the group, that they consider referring the standards, the medical standards, back to the SEMSCO, or the SEMAC, and subsequently SEMSCO, for community paramedicine programs. But right now, the question is that one, we can't expand those programs until that body meets and regulations are promulgated. And two, at this very moment in time, this body, it doesn't appear they have the authority to oversee CP regulations. On the other hand, and I'm sorry to belabor this, but on the other hand, if this truly is in line with the definition of emergency medical service as it exists today, which is a two-part test for scope. One, what can you do? What are you trained to do? What are you authorized to do? And two, where can you do it, or in what setting can you do it in? And so the current setting that limits us is the initial care and treatment of a patient. And so if it sounds like it might fall in that, if truly this is for unscheduled transports or unscheduled visits, low acuity unscheduled, it might fall into the definition as it exists today of EMS, but we're really going to have the legal folks take a look at that and opine.
Dr. Doino.
Hi, Mark, go ahead.
Hi, Mark Philippi. Two things. First, the point of order, we don't have a second for Dr. Berkowitz's motion. I think that's where Dr. Langston was going, right? And so I guess the first thing, before we can have further discussion.
Do you want to second it?
I'll second it, yes,
Okay,
absolutely.
great.
For the point of discussion, a nod to my esteemed colleague, Deputy Director Jazura, because that's exactly where I was hoping to rise in support of the motion. I believe this is certainly in keeping with our current understanding of treat and place. This is a treat and place encounter. This is a patient who has potentially called 911, correct, Dr. Berkowitz? That's the intent? So this is a patient who's called 911 for a encounter. EMS has responded. They have now engaged in a telemedicine consult, and no different from any other telemedicine consult, we're adding a medication that they can now add to their cadre, whether that happened to be potentially a diabetic that was given dextrose, or a Narcan patient being given Narcan in that instance. So I think that is one way to look at this that might solve those considerations.
Thank you, Mark. So just want to make it very clear before we vote. If we vote this in and SEMSCO votes it in, will they be able to go into effect, or will it need to be approved by the commissioner?
No, so all protocols that have to have dual sign-off. The commissioner can't do something without the SEMSCO, and the SEMSCO can't do something without the commissioner. So this, whenever we approve protocols, it goes up for commissioner approval.
But it's actually a pilot program.
It's after, right? So just to show that
Yes.
the commissioner is always the final sign-off.
Okay, even as a pilot program, you'll need to sign off. So just so it's clear, Scarsdale will not be able to start with this program until it's signed off by the commissioner, if it's voted in. Just want that to be clear. You can't walk away from today and start tomorrow.
Understood. This is just moving the ball forward, and that is still progress.
Okay. Any other discussion before we vote?
I have a question, Dr. Doino.
Sure.
So I guess I'm a little confused, and maybe just clarify for me, because we're talking about this in the realm of community paramedicine, but then Mark, I thought you just mentioned these are coming in as 911 calls, and so it seems like we're kind of blurring. I guess I'm confused on what exactly is involved here, and I guess it comes back to Dr. Cushman's original discussion about, defining these terms a little bit better. So one, in a second, John, maybe you can respond to that question. The other thing is, if we're talking about approving a pilot project, it seems like when we've done pilot programs before, we've had some, kind of more advanced, written out, defined language and procedures and things like that, which I don't think we have right now. So I agree with, we want to move these things forward, but I just don't know if it's appropriate for us to be making these decisions without an actual formal set of rules and definitions and knowing exactly what we are approving.
Yeah, so I think that there has been some document exchange regarding this, but there's the murkiness regarding the community paramedicine versus the low acute and scheduled part has probably clouded that up a bit, unfortunately. But the intent is these are unscheduled visits, just to be really clear, low acuity, and all are associated with a physician interaction and a physician order. How it comes to exist in terms of the is harder to say. It could be a 7-digit call. Who knows? Like there's a lot there that goes unsaid. One of the reasons to advocate for this is, first of all, it's not going to go into effect until it gets final sign off, and this will actually help us to force the issue and create the definitions. If in the end this goes up and they say, actually, this is what this would be covered by CP, great. Then we know that this is what's covered by CP. If we go up and they say this is something different, then great, we know that too. I think that this is will help us move things forward. So I agree with what you said regarding the murkiness, and that murkiness is going to continue to exist every time we talk about this until we push it past the next step.
Is there any more discussion for Dr. Baumberg?
In reading your protocol, I understand that the intent is that the first activation is the 911 EMS call. However, these antibiotics require redosing, and some of them require IV redosing, which means that you're going to need another visit from a community paramedic. So that doesn't seem like it fits into the 911 scenario. That seems like it, at least that part fits into the community paramedic scenario.
So that's a great question. In my discussion with the agency, the intent is one-time dose and then a handoff to another team that would be able to maintain the therapy. That is their plan. But again, there's a lot that I think we would learn from them building that process to help those patients. But the intent is not to be going every day to someone's house to administer antibiotics. That is not the goal of the program.
Any other discussion? Steve?
Yeah. So, question, just following up on what Mr. Philippi said. Is there anything in law or regulation that prohibits this specific physician from giving this order under a physician's discretion today in the single dose episode that you just talked about? It seems to me under some of the current treat in place programs that are neither enabled nor disabled in law, this might be simply permissible in a case-by-case basis as ordered by the physician.
Steve Desura, I'll take that. So it's an interesting question in that this body determines which medications and regulated medical devices are permitted to be carried by EMS personnel. And so by adoption of the protocol, you are thereby making it a medication that can be carried. And so, yes, that can be done. But absent the protocol and absent this body actually declaring that antibiotics are part of the approved formulary, then technically by regulation, no, a physician couldn't order it because there's nothing that allows EMS to carry it.
So,
thank you, Steve.
Just to make this even murkier, if this is a patient-specific order and it's prescribed to the patient by the physician, does the medication assistance protocol come in here at all? And
I'll say again, this is really going to take a review. There's so many factors at play that have to be evaluated, beginning with the two-part test of which scope does this fall into? Is it falling into EMS, the scope of emergency medical services as defined today, or is it falling under community paramedicine? That's the first question that needs to be answered, and it'll probably take some follow-up to understand where the use is. And I know we keep using the term unscheduled, but the reality is the statutory definition of EMS is the initial treatment. So if that patient, for example, and I don't know this, but if a patient is already under the care for this specific thing and we need to send an ambulance out to give an antibiotic on a patient order, it gets complicated as to, is that the initial treatment or is this an ongoing treatment plan? And so hence why it's not as simple an answer as it seems, and it's going to take us some time to review.
Well, we do have a motion on the floor, so we will need to vote, but is there any other discussion before we vote?
I just have one other comment, Dr. Doyna, and Deputy Director, that's something that actually concerns me as someone who has been part of a active and growing treat-in-place program. I have concern that if we start to narrow the definition of community paramedicine, or perhaps even broaden it to include treat in place, it's going to affect existing programs or the growth of programs that currently are not specifically regulated, because they do engage in that initial care. And that's where I'm concerned.
To your point, I want to make clear, we haven't evaluated each and every specific treat in place program, but the ones we have looked at do align with the current definition in that it's activated by a 911 call, and it's the first time somebody's making contact with this patient, which is the initial care. And therefore, those programs, the ones we commonly previously referred to as ET3 programs, were allowable under the existing definition. It's when we start doing things beyond that, follow-up care or there's so many different scenarios, but that's where it gets a little murky. But treat in place is not a murky question for us. That's initial care.
I suspect we should vote on a motion now and let the courts deal with this when the time comes. That's the opinion of any of us, including with respect to the Bureau of EMS. It's not a definitive opinion. It's what a lawyer says, and lawyers win in court. So we need to vote on what we want to vote on, and then afterwards they'll find it out.
All right, any other discussion before we move on? All right, if we can have a roll call vote, that would be appropriate.
Dr. Berkowitz.
Berkowitz, yes.
Dr. Bombard.
Bombard, no.
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 Okay. Dr. Cooper.
No.
Dr. Cushman.
Cushman, no.
Dr. Daly.
No.
Dr. Doynow.
No.
Dr. Isaacs.
Isaacs, yes.
Dr. Kugler.
Kugler, yes.
Dr. Markowitz.
Markowitz, no.
Dr. Murphy.
Murphy, no.
Dr. Olson.
Olson, no.
Dr. Raybridge.
Raybridge, no.
Dr. Walters.
Walters, no.
And Dr. Winslow.
Winslow, no.
Motion does not carry.
Okay, thank you.
All right.
Raybridge?
Yes, and just to close that conversation out, I think there was discussion there as well as here on perhaps there should be some representation of this body to this working group to address these concerns. So didn't want that to get lost in the conversation.
Okay.
And then finally, from Med Standards, we had a presentation on the iGel project and the great work that the team in Hudson Valley is doing, trying to collect that data, and brought up some questions and concerns around data collection in general and how much time and effort they've put into this and their ability to collect all the data. So I don't know if Dr. Murphy, if you or Mr. Villain want to give a quick summary and
David can present the exact data that we have again, but to sum it up, we have quite a few agencies that have become involved that have trained and started using the iGel. I think the pilot project's been very successful. It's like blossomed through the whole state. But the one thing that was most of our discussion was how poorly it is technologically, let's put it that way, to gain access to the data. David, do you want to give them a nutshell of the data? How it declines rapidly from what we have access to.
Sure. Thank you, David Violante from the Hudson Valley region. And I'm going to talk quickly just about data that we had from a few weeks ago. Where we had 164 potential cases here that we saw. 131 made it to the state bridge and 98 came out to the state report. As of this last week, we had 239 cases, insertions. 177 made it to the state bridge and 114 made it to the state report. There's a variety of reasons for this, for providers documenting in a narrative section versus drop down, so the data is not available. Dialect differences among vendors going to the state bridge, just transmission errors themselves, and some problems in getting the data off of the state bridge into the state report. So those are some of the reasons, and we're trying a bunch of workarounds to get the data from getting PCRs to the Hudson Valley region, Drupal forms, actual data from the agencies themselves, and continuing to work with the DI team to get the data up to them so they can provide it for us. We've done a lot of work in reaching out to organizations and agencies to get the data, tell them when it's not going across, and trying to get it from them in a variety of ways so that we can present the data to you and show the program works. Of the data we have, it does demonstrate that the program works. EMTs can actually insert an iGel in adult cardiac arrest pretty effectively. I can report some of that data if you'd like, sir.
No, I appreciate that, and I think the summary of the discussion earlier today was very good, and I think the consensus of the group was that we have work to do around data collection and how we get these data for these projects, and it was suggested that perhaps there be some working group to kind of look at this and make recommendations about how we could kind of standardize these things. And that concludes the Med Standards.
Okay, thank you, Dr. Raybridge. Education report. Don Hudson?
I was hoping you were going to skip me. Guess not. Nice try. I tried the no eye contact thing. So we're going to have three voted motions going forth to SEMSCO. The first is to, as this body just did, reaffirm the timelines and the plan for EMTCC cessation or sunset. The second motion will be to allow calculators on all New York State certifying exams. That's also in parallel with what the National Registry has allowed for some time. The third motion is to also in concert with the National Registry ceasing the availability of their practical skills exam this year to allow New York State, under I guess what could be phrased as a pilot, to move the current paramedic original practical skills exam from the end of the program built into the program in building what we know as is the paramedic skills portfolio. So same skills, just not tested at the end, verified throughout. Happy to take questions and move along.
Any questions? Thank you for your report. Dr. Cooper, EMSC.
Yes, thank you, Dr. Dornell. We've had actually a very busy time in the EMSC committee. We met on December 4th as well as February 1st, very, very briefly in the interest of time. A lot of our activity recently has been focused on the Always Ready for Children program. I urge every single one of us to look into that program and make sure that your emergency departments have responded and have joined this program. So far, only 7 emergency departments throughout the state have joined the program, soon to be an 8th. That would be mine. And Amy Eisenhower can fill you in on all the details. And I will ask Amy to get the web link out to all members of SEMAC at the conclusion of the meeting. Work continues on expanding the PEC programs, the Pediatric Emergency Care Coordinators, both at the emergency department and the EMS service level. Work continues by the National Association of State EMS Officials Group on the transport safety initiative. The EMSC federal program has been strongly advocating for what they refer to as the Family Action Network, and Nicole O'Toole, who is our representative to EMSC, is with us here today. And this looks to be a very promising partnership aimed at ensuring that families of children, particularly children who have had interactions with the emergency medical services system, are properly represented. Work continues on the pediatric agitation training program, where our thanks go out to Chief Pataki at the New York City Fire Department Bureau of Training, who's assisting us in developing scripts and videos of 3 different common scenarios encountered in the field in terms of agitated children. Megan Williams of Bronx Municipal Community College, Manhattan. How could I confuse that? Borough of Manhattan Community College. I live in the Bronx, sorry. And she has been leading an effort using her students as research assistants in thinking through the issue of differences in the various methods to calculate drug doses in children in the field, Hantevi, Braslow tape, etc. And she'll have a report for us at the next meeting on that. We had a lengthy presentation similar to the one that was given here, I believe in our September meeting, if I'm not mistaken, on the CSCs, the crisis centers, and more to come on that. Given common interests in terms of pediatric agitation, the crisis center folks will be joining the work group on pediatric agitation to work that through. Dr. Elise Vandriat, Vice Chair of the committee, continues work on pre-hospital procedural sedation, and the committee is considering potentially in the future developing a guidance on that for all emergency departments in New York State. Our colleagues at the Quality Bureau in the department are continuing to advocate for the pediatric sepsis program. We expect a report from the 2021 data at our next meeting, which will take place on May 6th. Our colleagues at PCARN, the Pediatric Emergency Care Applied Research Network, continues their work on the TREX program, which basically stands for Treating Respiratory Emergencies in Children, focusing on asthma treatment. Dr. Marilyn Kasika, who heads the Bureau of Family Health within the Health Department, is updating the Pediatric and Obstetric Disaster Toolkit, and our committee will be playing a role in that. The Pediatric Trauma Subcommittee of STAC focused on an apparent discrepancy in the data with respect to traumatic brain injury outcomes in older adolescent patients. It appears that the previously identified potential slightly less than desirable outcomes in that age group probably is due to a data glitch, and so more work continues on that. And finally, and perhaps most directly relevant to this group, is the fact that the SEMSCO statement on use of pediatric pads for the LifePak 12 and 15 defibrillator monitor units is a cover letter from EMSC calling everyone's attention to the fact that the appropriate pediatric pads have to be used with these units, is going through the EDCC process, and ideally will be available within the next few weeks, at least according to the latest information we have from Ms. Eisenhower. It's a lot to digest, I know. We've been very busy. We can plan to continue being this busy as we move forward. And as always, my personal thanks go out to Amy Eisenhower for the incredible work she does on behalf of the children of New York State, not to mention all of us on the EMSC committee and, of course, SEMAC as well. That concludes my report. I'll be happy to answer any questions if there are any. Thank you, Chair Doyna.
Any questions for Dr. Cooper? Okay, seeing none, let's move on. Any old business? This group is very quiet today.
Dr. Doyna?
Yes.
I know the director's kind of walking this way. It just, we had a discussion earlier, and I just wanted to ask him if he could comment on the EMS medical director insofar as he's able.
Sorry, you asked me to comment on what?
The EMS medical director and where that stands.
Sure. So the EMS medical director that did go out as a contracted position, and it was, I think we were even trying to fill two. We were trying to fill one first as a contracted position. The process was not successful in finding a successful candidate for that position, and now we believe we're taking a slightly different track and going back to, and now have the funding for a full-time state EMS director. So that's a difference in directions, but now it's back in civil service track to move that forward. So I think that's why you heard the remarks before of there'll be many people who will be happy, maybe some who won't, because they'll turn and say, I don't want a full-time position, I was preferring the part-time, but that is the motion that we're moving in at the moment.
Thank you.
Absolutely.
Any other old business?
Just one element of old business first that's still out there. We've had discussions here before about our school nurses and Stop the Bleed kits. That discussion was ongoing. Unfortunately, with the retirement of Dr. Morley, the established connections to state ed have fallen apart. We're going to try to resurrect that now with Dr. Fish, see whether or not he can help us move this forward. There continued at the last time I heard, which was in December, to be concerns with some of the language that we had put forward by state ed, in spite of the fact that we reminded them one more time that hemostatic dressings are indeed not a drug, but an FDA determined device, much like a tampon, for example, the same class. So hemostatic dressings in school nurses remains a issue of concern, obviously, for the people around this table, the people at the stack, and most importantly, of concern to our school nurses who feel like their licenses may be in jeopardy because of the statements of the Board of Nursing. So hopefully that will come to resolution.
Thank you, Dr. Daly. Any other old business? Dr. Winslow.
Yeah, I just wanted to say that the SEMSCO and SEMAC credentialing working group has been meeting. Currently, we're reviewing each region and what they're currently doing for regional credentialing and reviewing 4 related policy documents, some of which kind of seem to interact and conflict with each other. They're 1103, providing medical direction, 1401, EMS provider restriction guidance, 1105, medical control and oversight, and 0503, air medical credentialing. I want to give a shout out to Mike McAvoy and Paul Barbara for their leadership of this group, which I've been a part of. I recommend all SEMAC and SEMSCO members are invited to participate in the discussions. We meet on Mondays at 2 o'clock virtually through the Boardable app, and the next meeting is 2/19. Right now, there's been great discussion, but we clearly don't have anything to share with the group.
Okay, thank you. Any other old business? Moving on to new business. Anybody have any new business? Dr. Daly, you look like you're ready.
So one thing that Dave Violante did for us as he made his excellent report on the supraglottic airways that I think is incredibly important for this group to remember is that from what started as 239 applications to supraglottic airways, he ultimately could easily extract data on 117. That's kind of grotesque. Peter Brody and I have certainly had conversations before about the challenges of working with 17 different EMS documentation platforms. But I think that also leaves us in a position where we have to look at any of the data that we are establishing as official EMS data. And we need to work through any of the pilot projects that are out there to make sure they include a documentation section, validation process, systems for auditing, and we need to recognize that this will be a continual weak spot for us as we try to interpret what our medical decisions need to be on the part of folks in New York. We already have a group that was starting to form and starting to work on the idea of how we can integrate EMS data into the rest of the concept of data across the spectrum of healthcare. That included participation from STAC, from Haney's, from FIPIC, from the Bureau, and from elsewhere in the department. There has not been a lot of movement with that group, although we initiated discussions. But I would just encourage this group to continue watching to make sure that that group is moving forward, and that we are working on making sure our data is really going to impact our patient care as much as possible.
Thank you, Dr. Daly. Any other new business before we close the meeting? Okay. The next SEMAC meeting will be May 8th. It will be here in Troy. Hopefully the weather will be a little bit warmer. Can I have a motion to adjourn? Thank you, Dr. Cooper. Second by someone. Dr. Olson, all in favor? Anybody against? Okay. We'll see you in May.
Hey, Mike McAvoy, I have the privilege to call to order the meeting of the State Emergency Medical Services Council. Welcome members, participants, and observers. As a reminder, this meeting is subject to open meetings law and is being broadcast over the internet. So that you know, these webcasts can be accessed at the Department of Health website at health.ny.gov. The on-demand webcast will be available no later than 7 days after this meeting for a minimum of 30 days, and then a copy will be retained by the department for 4 months. A suggestion when you're speaking, please indicate who you are and identify yourself as a council member, DOH staff, or in case of a public member, introduce yourself when you come up to the microphone. If we could stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. If the secretary could call the roll.
Allison Burke. Stephen Katie. Scott Clark.
Here.
Dr. Krupe.
Here.
Mark Devers. Here. Don Duval.
Duval, here.
Michelle Fornes.
Mickey Fornes, here.
Carl Gandolfo. Gregory Gill.
Gill here.
Jason Haig.
Jason Haig here.
Teresa Hamilton.
Jerry Gelbart, alternate for Teresa Hamilton.
Thank you. Donald Hudson. Dr. Isaacs.
Present.
Al Kim.
Al Kim here.
Steve Kroll.
Steve Kroll, present.
Andrew Knoll.
Andrew Knoll present.
Jared Cutson.
Jared Cutson present.
Al Lewis.
Al Lewis present.
William Masterton.
William Aston present.
Michael McAvoy.
McAvoy present.
Elizabeth McGowan.
Elizabeth McGowan, present.
Mark Philippi.
Philippi, present.
Marianne Portoro.
Marion Petoro, present.
Dr. Ray Britch.
Ray Rich present.
Dr. Red Leonard.
Red Leonard present.
David Simmons. Carla
Merrill
Simpson.
Montrose, alternate.
Okay. Carla Simpson.
Carla Simpson, present.
Christopher Smith.
Christopher Smith present.
Chad Smith.
Chad Smith present.
David Violante.
Violante present.
Roll call complete. We have quorum.
Excuse me, Mr. Chair, Hudson present. I just walked in.
So noted. First item of business is to review the minutes of the December 6th, 2023 meeting. Any comments, corrections, death threats, otherwise? Or
Motion
I'll
to-
entertain a motion to
Motion to
accept them.
approve, Mr. Chairman.
Second.
Any discussion? All in favor, signify by raising your hand. Any opposed, same sign. Any abstentions? Carries. Next is correspondence. I have 2 items of correspondence, one of which was referenced at our meeting in December, and that was a letter from Milrems, which is a 2-page long letter basically with some concerns and issues regarding instructor training, availability of CICs, and the process by which those folks move through the system. That has been addressed by the Training and Ed Committee, and unless anyone wants me to read the entire letter, that has actually been affected in the way that Milrems asked for it to be moved through the chain.
Mr. Chairman, on behalf of the Monroe-Livingston region, I appreciate the chair's recognition of that letter, and I understand as well that the Bureau staff are working closely with our Training and Ed group to address those issues, so our thanks.
Thank you. Second piece of correspondence
just on the Melrose letter too, I just want to say thank you to Melrose too for identifying what they see as some issues and troubles, some of which we were aware of, and working with, I think, at the point of getting a letter, but also some that I think just further emphasize things that maybe we weren't aware of. And so that opportunity to be able to see it, respond to it, address it, and work together on mutual expectations really was appreciated. So thank you for that one. And to any region that feels that they're having issues or specific things related to instructors, education, the opportunity to write a letter to the Bureau or to the State Council or anything to work on solutions, we encourage. We know that, some things take longer than desired at times, but we work on a regular basis to correct that. But please don't ever assume, I guess, that what I would say is that we always know of every issue or things that kind of are a problem, and you're welcome to bring that at any point to us.
Question, Mr. Chair. Would that be made part of the minutes then? We could read it at our leisure, that letter?
It was posted on Boardable for members.
And it is a document, I believe, is also up. It's not posted on the website, but it's listed as a document for correspondence that they'd have to contact Teresa, but she can email that out. There's some particular personal their names that are mentioned, and so that's the reason on that one.
As Mr. Lewis is the second correspondence received December 20th from the Southwestern Regional EMS Council. And it is a request to delay sunsetting of the critical care level until July 1, 2030. To whom it may concern, I am writing to express the position of Southwest Regional EMS Council regarding the proposed sunsetting of a critical care level within New York State EMS. We appreciate the ongoing efforts of the Training and Education Committee to review and enhance the EMS curriculum, ensuring the highest standard of care for our communities. After careful consideration and consultation with our stakeholders, Southwestern Regional EMS Council strongly recommends that sunsetting the critical care level be delayed until no earlier than July 1, 2030. Our region has experienced the benefits of having critical care level providers who bring advanced skills and specialized training to the pre-hospital setting. These providers play a crucial role in improving patient outcomes, especially in cases where a high level of care is required during transport. Sunsetting of the critical care level will prematurely lead to a crisis in our region. We acknowledge the need for periodic review and updates to EMS education and certification standards. However, we believe that extending the time frame for sunsetting the critical care level will allow us more time to address potential challenges in bridging to paramedic and ensuring smooth transition for the EMS providers in our region. We appreciate your attention to this matter and your commitment to maintaining the highest standards of care within the New York State EMS system. We look forward to an opportunity to work collaboratively in ensuring that any changes made to the EMS curriculum align with the best interests of both providers and the patients we serve. Thank you for your time and consideration. Tom Sanson, Chairman, Southwestern Regional EMS Council. And this will be an item of discussion on the agenda later today. That's all the correspondence that I have. Next item is Chairman's report, and I want to take a second to present an award to Michael Benamati, if he could come up here. This is an award that is given annually by the folks from PulseCheck, the New York State Volunteer Ambulance and Rescue Association. And where is he? Oh, there he is. Coming from behind. And it basically says this is presented to an individual for consistent work spanning 10 or more years through teaching, publication, or research, and in addition have a profound impact toward improving EMS services or systems at the local, state, or national level, including a positive impact on the volunteer nonprofit EMS community. And this is proudly presented to Michael T. Benamati from the LaGrange Fire District, who, as you all know, is the gentleman who was responsible for the report heard around the world on EMS system sustainability. So congratulations. And I'm probably going to ask him to talk about another project a little bit later on today. That is all I have. First, Vice Chairman.
Thanks, Mike. I have nothing to report for this meeting.
Okay. And under second Vice Chairman, it says that we're going to have a training on boardable. We were advised by council that since that applies only to the people seated at the table here, that might not be the best time to do that at an open meeting, since the open people have no idea what boardable is, nor do they care. So we'll schedule that with a WebEx or a actual boardable training, and then we'll record it so that members here who do use boardable and those sitting around the room who bash their heads against the wall attempting to use boardable can figure out how it works at some point in the next month or so. I'm also going to make some slight tweaks in the order of committees because there are a couple of them that require someone else to talk prior to them for you to understand the flow here. So we'll start out, I guess, with the EMS staff report. Director Greenberg.
Thank you so much. Welcome, everybody. And I actually have the honor at the beginning of our Bureau report to introduce Deputy Commissioner Dr. Doug Fish, who is the Deputy Commissioner of OPCHSM, which is the office of which we report up to within the Department of Health, and has come to join us for part of our meeting here today and wanted to give him the opportunity to say a few words, introduce himself. He is formerly, you might have known Dr. Morley, who was in the Deputy Commissioner spot, and Dr. Fish is the new Deputy Commissioner.
Thank you, Ryan, and good afternoon, everyone. It's a real honor, privilege to be with you today. As Ryan said, Dr. Morley retired in December, so I stepped in an acting deputy commissioner role in our Office of Primary Care Health Systems Management, so it is a real privilege to be with you. My background is for the last 9 years, I've been with the department in the Medicaid office, so I've been the chief medical officer and still working in that capacity while I've been doing this acting role. Have learned a lot about the department, but I'm learning a lot more now. So it's been a really good experience. Before that, I practiced for over 20 years internal medicine, infectious disease, and still see patients in the hospital on weekends where I do consulting. All that to say just how much I personally and we in the department value all of the work that you do day in and day out to keep New Yorkers safe. So it's a daunting task that you take on without complaint. So we're just deeply appreciative and thank you for all that you do to advise the department, our office in particular. We are indebted to you for your service, so thank you for that. And I have had just the great opportunity to work with Ryan and Steve. It really started, I'll just mention, at Javits, right? That's where we first interacted. So you all came to that public health emergency just so willingly and graciously, and it was endless hours that everyone put in during the pandemic. And to know I was on the ground in Javits with Ryan and Steve and all of you in your various communities. So thank you for all that you did to help us get through and navigate and survive the SARS-CoV-2 pandemic. And I just will pause and take a moment and see if you have any questions. If I can't answer them, I'm sure our team can, but just wanted to give the opportunity and again to say thank you for what you do. All right, Ryan, back to you. Thank you.
Dr. Fish, I feel obligated to tell you that the questions normally don't come on the first time, but as soon as they feel comfortable on the second time, there's normally many. But I will say, again, I think, Dr. Morley came to us and started his career as an EMT. Dr. Fish is, with us now and truly boots on the ground. We work together at Javits many hours and late nights, and so really excited to have you here and a part of this and a part of the team. So going into the Bureau report, for operations, we continue to do our initial, prior to full service inspections, we continue to send out the survey for the self-assessment of an agency. We had a really interesting update in this in the past 2 days, where we're going to be working with the Quality Committee to take an opportunity during those full service inspections or at the end of those full service inspections to share some additional information related to quality and to share maybe a one-pager that the Quality Committee is going to come up of where agencies can find additional information, what they can do with some best practices, and what they can look for work. We recognize that a full service inspection is part an inspection, but it's also an opportunity to learn. It's an opportunity for our district chiefs to share information out there, to share things with other agencies so that they can see kind of best practices from around the state and, kind of bring them into their agencies and not have to recreate the wheel. So we're happy to see that one move forward. On the administration front, we continue to move forward on putting contracts in place and paying invoices and paying, having the program agency contracts and the REMSCO contracts have their invoices submitted and things of that nature. We had a really good conversation on Monday with the program agencies talking about a number of different things, one of which is in some cases we see in about a third of our program agencies underspending in the REMSCO funding. And so we're going to share some of that additional information out. But one of the other things that we talked about there was what are some other opportunities that REMSCOs can spend money on? So how would they spend money? And so that opportunity there. So we're going to work on some of those things in order to get the money that's allocated out there and it's there or it disappears out to those REMSCOs that would like to use it. Same thing on the program agencies. We have many program agencies around the state doing, excellent work and helping with each of you within your regions. And, yet we still see an underspend in a lot of that. And so one of the asks that came up in this one with the program agencies, well, how is that or why is that? And can we help each other in spending that? So we're going to be sharing some additional information with that program agency groups on that one, as well as there was an excellent report given to us on, sign-in sheets going around. There was an excellent report given to us from the Finance Committee related to funds and aid to localities. So for those of you who aren't aware, our aid to localities funding pays for program agencies, it pays the REMSCO funding, and it pays education. Well, for the past several years since COVID, really, that prior to COVID, that group or that pot of money was spent every year. It ran out every year. It was great. And since then, it has been several $1 million underspent. And so we are working towards that of how do we get back to making sure that we're providing enough education out there, as well as some of the initiatives that was given from this body, from the Finance Committee. I think Steve might talk about it later, I'm not sure. But some recommendations from there for some increases in different things to see some additional funding. So there are recommendations in to have certain components of that have increased funding coming along with it in the future, something that I'm sure many of your program agencies would say they haven't seen since I think 1999 was the last time that we saw that. And then the ultimate goal will be is to see regular, maybe even smaller increases so it's not just stagnant. There is money that's within aid to localities right now that we see would be able to make these initiatives possible. And so we're excited to see that come up in the future as well. So we'll be moving forward on that one, again, working with several different groups in order to make that happen. So in the world of education, we have several pilot programs out there. This is my ask to everybody in the EMS community that's watching, as well as everyone around this table. These pilot programs were developed out of asks from each of you. How can you improve your agency? How can you improve your ways to get members in? How can you improve different things on providing education for free? And so we created these pilot programs. And we've had a lack of engagement related to these pilot programs. And so we're really trying to figure out how do we increase this lack of engagement. One of the pilot programs is an academy-style class, paying reimbursement at a higher rate in order to be able to train EMTs and train EMTs in a shorter period of time. And we just haven't had that many apply to run those programs. One of the suggestions that came up in the past 2 days was to possibly do what we did when this program was originally established. When it was originally established, it was established for 650 EMT seats to learn how to become an EMT. And it was done with about 400 of them going to National Guard and 250 going to civilians. We were told literally across the board that they ran out of seats. They didn't have enough. They wished they would get more. And so when we made the Academy-style pilot program, we thought, well, if we make it for every course sponsor, it would run out of seats again. It'd be another good thing. It hasn't taken that same path forward. And so one of the recommendations that came forward was, well, can you do it with a set deadline? Can we do it at the same time again that you did with the first one? Maybe that will attract, then you can advertise in the same thing. So it's one of the things we're going to look at. We're going to see if we can do it as a coordinated group and, maybe have 20 classes happen at the same time, the way that we did the last time. I think Chief Chesney is looking at me right now like, hold on, I know what the work was like for the last pilot program when we did this all at once. And so we're going to look at it. One of the things is with hopefully a little bit more advanced notice and not as crunched together. In addition, in the world of education, we have our CME and our reciprocity programs that really fell behind what our normal processing time is. And so we've looked at some best practices. We came together as a group. We've added some additional resources to it. CME is, looking good right now in regards to it. We updated some processes, so even simple things like technology, when we looked over these things, simple things is when you hit submit, it took you to a blank page. We've changed that. So when you hit submit, you get a confirmation number and you actually know that you submitted something. Sometimes it's the simple stuff. We've also added some instructions into reciprocity related to please, look at this email address. This is where you will get information so that when you upload your national registry card 4 times and we say that doesn't count as your ACLS PALS, your CPR card, and your other documents, that we can email you back and you get it. So we've done that as well. Our reciprocity has gone from over 3 months in processing, being able to get that initial review, down to about 2 to 3 weeks. So really outstanding work in moving that forward and being able to get additional providers out on the road and into your agencies that are there. From the regulations point of view, education regulations, they were out for public comment. They closed yesterday, and we did get a number of public comments. Thank you for everybody who did respond. We're working on our part now internally to respond to look at all those and evaluate if there's any significant changes that need to happen. If significant changes do need to happen, it will go out for public comment period again for 60 days and then come back. If significant changes do not need to occur, then you will see them most likely at the May meeting. We'll be able to implement those changes at the May meeting, including moving from a 3-year to a 4-year certification, because that's what most people tend to notice in that one gigantic packet. In regards to NEMSIS and our data and informatics folks, 3.5 is out. The schematron is out. You can start as early as next Tuesday if you chose to roll out 3.5 in your community. The big one to understand is we used to have just about 900 rules when you wrote an EPCR. The new standard of 3.5 brings it down to close to 350 rules. So you should see a pretty significant difference in your ability to chart and get things done and do so in a timely manner in order to be able to move things forward. So excited to see that moving forward as well. You are required to have it in place by July 1st. And just a reminder to everybody, it is the agency's responsibility in order to make sure that their charts are completed and uploaded and received by both the state and the hospital. It's not the responsibility on behalf of the state. It's not the responsibility of the vendor per se. So we will be looking after July 1st at enforcement to make sure agencies are submitting their charts in a timely manner. If the agency comes back to us and says, well, it's not my fault, it's my vendor's fault, it is your responsibility to work with your vendor in order to ensure that you have compliance and that your charts are getting to the appropriate places in the appropriate times. EMS for Children continues to do a lot of different projects around the state. Amy Eisenhower is out there on a regular basis doing a lot of education, delivering different things. And one of the big things that is out there now is we have an emergency department program for Always Ready for Children, which supports pediatric readiness. This is very much like the PEC program that you see for your agencies. By the way, anybody who wants to sign up for one, please do. And it is now out there for emergency departments as well. There's also an EMS for Children survey that will be coming out in May. That's a federal survey that comes out to see how EMS agencies in New York State are doing related to related to care of pediatric patients within New York State. And then last on the EMS for Children side is the next advisory council meeting is here at the Hilton Garden Inn on May 6th. Vital signs coming up in October. Call for speakers just closed. We had a record number of call for speakers this year, more than we've ever seen before. Vital Signs 2023 was really successful. We hope to see that success happen in 2024 as well. It will be happening from October 16th to the 20th. We were actually just out there for a planning meeting and really excited to see the space, really excited to notice that we can add more tracks and do things that in some other spaces just doesn't have the space to be there. Looking at both, things that are on the educational front, but also things for those who come to be able to see the city, to be able to see more, to be able to see this amazing museum called the World of Play and the Strong Trauma Center and different things. So we're really looking at a lot of different things that are out there to kind of increase your education, but also offer you the opportunity to see another part of the state. And for those of you who don't know, I know I mentioned it at SEMAC, but I'll mention it here too. It is the home of the first Wegmans. I've learned a lot about Wegmans and supermarkets. This place is incredible. When you turn and say, why did Director Greenberg say I should go to a supermarket for dinner? When you go there, you'll understand. I'll just leave it at that. Make sure you go to the mothership. The last part of Vital Signs this year that I'll bring up on Vital Signs is related to special operations. So we have a new track this year, a special operations and rescue track. This is feedback from our EMS community related to wanting to know more, wanting to, be out there and do something different. For those of you in EMS as well, if you are really hardcore into your special operations things, don't forget about down in New York City on May 2nd to the 5th of 2024. They also have their special operations training that happens at their fire academy, and it's incredible. So I'll just leave it at that one. So 2 different options for some education going on in that one. Our memorial happens Wednesday, May 22nd this year. It's on a Wednesday, not a Tuesday. There are 8 honorees that are going on the wall, and that will hopefully include our new EMS memorial. So our tree has filled up and it is time to expand, unfortunately. As we expand, we will have a tree in the middle, and then there will be 2 wings that will have the names engraved, and people who come will be able to etch the name of their loved one that is up on either side or either one of the wings as it's described. And thank you to everybody on this council who helped in planning and designing the new memorial. Some other things, just in other items. So the blood regulations are moving forward in order to have be able to store and carry blood in Air Medical. The Community Paramedicine Advisory Group is being developed right now, and they'll be working on community paramedicine regulations related to the pilot program that is currently in place. The County Assistance $5 million grant, which is a grant that will offer up to $500,000 for 10 counties is moving forward. Hopefully that will be out in May or June of this year. And OASIS. So we had a mental health and well-being program that was run by Jenny Solomon from the Bureau of EMS that was funded by OASIS for the past couple of years. That will be coming to a sunset the live classes will be coming to a sunset in March of this year, and we're really excited to see that we'll continue online training, but the opportunity to train several hundred providers over the past couple of years in this additional training, an 8-hour day of how to deal with patients with substance abuse and mental health illnesses. We know this is a big issue, and we know that this is a factor of things, but I just wanted to stop and thank Jenny for all of her work that she's done over the past couple of years with this one to make this project as successful as it's been. So thank you, Jenny. On regulations, we spoke about education just a few minutes ago. The equipment regulations are continuing to move through the process. In relation to the Rural Health Ambulance Task Force, I think somebody is he going to be giving an update later? Yep, so you'll be getting an update later on that one, so I'm going to stay away from that one. There is with Part V, so the budget has Part V in it, which has a lot related to EMS, essential services, and expansion of community paramedicine program, and a number of different things. We'll be doing WebEx sessions for all the SEMSCO members, the SEMAC members, the REMAC members, the REMSCO members, and our EMS community as a whole. So we encourage you sometime over the next couple of weeks to join us for one of these meetings. We'll be posting those dates. The EMS leadership call, which happens on the 3rd Thursday of every month, this month has been expanded from 1 hour to an hour and a half. In order to do that presentation there, you again can sign up right on our website. If you go to EMS forms page, there's a drop down there to sign up for those leadership briefings. This month it will be related to Part V. One of the things that's also come up is a state EMS task force. So there are 2 one-page flyers that should have been given to everybody on this, on any of the councils, and they are public documents. We'll share them with everyone. There are 2 two-pagers. One of the 2-pagers is related to Part V. It talks about each of the sections, breaks it down a little bit, what it's about. The other one is related to state EMS task force. So state EMS task force was put into legislation last year as an initiative in order to be better prepared for disasters when they happen and being able to mobilize quickly. And so that 2-pager talks a little bit about the task force, what the framework will be, where things are moving forward with. The biggest part of the task force is our public-private partnerships. So the task force will have about 60 ambulances, but won't have an ambulance. It will have 60 ambulances through partnerships with local agencies. They will be paid for readiness. They'll be paid to have one of their ambulances available and ready should a disaster occur and to be able to roll that out. There'll be 25 BLS ambulances, 25 ALS ambulances, and 10 critical care ambulances that will be under contract. That contract and payment for readiness also allows us to be able to turn a switch on in a matter of hours opposed to a matter of days because there's already a contract in place. This is a huge factor. When we talk about that snowstorm from last year, we talk about Buffalo, and we talk about how long it took us as a state to be able to help a local area. It took us 6 days. Under this task force, under these contracts put in place, we'll be able to make that happen in 6 hours opposed to 6 days to be able to mobilize and make these things happen. That's a huge difference, and we're really excited to see that. In addition, there is state staff who will be hired full-time. There are a number of positions in there. About 80 paramedics will be hired statewide throughout the entire state to help with our day-to-day preparedness, to help with the readiness, to help with the equipment, to help with other things. When we talk about great ideas and concepts coming out of these 2 days, this is one of them. We had a conversation like, well, we need every paramedic we could. Al Lewis on a regular basis reminds us of that, in the field and doing these things. And so we need a lot of different things in order to make things function, in order to make us ready to respond to a disaster or an immediate emergency when things happen. And so there are about 80 positions that will come into this task force to help the day-to-day planning. Now, in understanding that and hearing some of the concerns of this one, over the course of 2 days, we also recognize we need to work to help increase the number of paramedics to make sure that there's not, a number that goes down. That 80 number seems like a lot, but that's also over probably a 2-year period-ish. It depends on timing of things. And what we're going to do at the state is we're going to look to see for every paramedic position that we look to hire in the state, can we fund an EMT to go to paramedic training to make sure that each of those positions is, backfilled or supplemented in the EMS community? And then I think if we set up the model correctly, maybe we can even continue to do that after. So if there's, 80 positions that are 80 people who are trained as paramedics under state funding, is there another 80 after? Is there funding for another 80 after? And then continue to not just keep the number the same of paramedics around the state, but to increase the number of paramedics around the state. And so the task force will be working on different initiatives like that as well. The task force will also be purchasing specialized equipment and supplies and things like that, in order to move that forward and be ready and to be able to respond in a short period of time should the need exist. Zones, thank you. So one of the big questions that we get with the task force in this flyer, if you look at it, you'll see that the task force is separated out into 5 zones. This is not the districts from last year, probably the biggest question. Zones are not the districts from last year. All the zones do is allow us to make sure that we have allocated resources and staff around the state in order to be able to respond to an emergency anywhere in it. Each zone has 2 economic development areas within it, and if there's an emergency, let's say in Nassau County, and there's flooding, and Nassau County calls the state and says, we need additional X, what we would do is not pull resources from the zone in which is affected. So if zone 1 is affected, we're going to work from zone 2 or zone 3 or zone 4, pull those contracted resources in from those zones, pull those specialized equipment in from those zones, so that we're not affecting the local resources, which probably are already taxed if they're calling us at the state level to say, we need help. So the zones are literally just the distribution. Each zone will have that catch of 5 BLS and 5 ALS ambulances under partnership with those public-private partnerships. The zones will be divided again, so that we know how to respond or where things are, as well as to make sure that there's a certain amount of equipment in each part of our state, and that is the zones within it. They are truly working within the system and working within that given area in order to supplement and provide additional resources. Last but not least, there are two people who I'd like to mention. So Dr. Lou Marshall, who I think unfortunately had to go home and already, so he is on his way back down to New York City. He has served the council for almost 25 years and almost 20 years, I think, as Med Standards Chair. He did say that he became Med Standards Chair because he made the mistake of going out for a cup of coffee and came back in and became Chair. But I will say it was probably one of the best decisions, both that he made in going to get a cup of coffee and whoever was in the room to move him into that role. He's a phenomenal leader. He's done amazing things for us at the state, I think in the New York City region as well under his leadership down there, and really has been a true mentor to me and many of the department staff on, protocols and just history. I would ask him questions on certain things, and all of a sudden 2 days later he'd call and say, I looked this up, by the way, I read the minutes from, 2004, and we said this. And I was like, how did you even find that? So I just want to say thank you to him for all his leadership, his years of service, and his commitment to the EMS community and his physician direction. So thank you, Dr. Lou Marshall. Second, I would like to thank our immediate past chairman, Mark Philippi, who has been sitting on council for a number of years now, and closer to the amount of time that I've been here. But his term is coming near to an end now, and his service, his time, his commitment, and his commitment to making sure that I moved things forward or different things and didn't lose track of time was absolutely incredible. We spent many late nights on the phone calls together. His drives back and forth were sometimes the perfect time to capture, I think, both of us. But the ability to take a committee like this and really unite it, have it focus on, a common goal, have it move things forward is something that, I think many leaders strive to do. Not everybody achieves it, but it is absolutely something that you've achieved. We've achieved amazing things over the past couple of years under your leadership, and I would like to say thank you for everything that you've done as chair, everything that you continue to do for the EMS community, and everything that you've done to make EMS advance in New York State. So thank you very much. With that, that's the end of my report.
Any questions for Director Greenberg?
Yes. So with regard to community paramedicine, you talked about the advisory group, and as you know, there were some lively discussions around community paramedicine earlier today, and I think the consensus of the physician participants is the importance of an EMS physician representative of those bodies participating with that group to kind of see what the role of these groups, SEMAC, SEMSCO, are, and to advise from an EMS point of view as being the physicians who have the best understanding of paramedic scope of practice. And so just bring that to you as a suggestion from those groups.
I think that was made during the last one. I appreciate the suggestion, and we'll absolutely be looking to make sure that there is representation of, our state council members, informing that committee.
Thank you. With that, we're out of time. I'll take a motion. No. CMAC Chair, Dr. Doyna.
This will be rather quick. As Ryan mentioned, we did thank Dr. Marshall for being the Med Standards Chair for over 20 years, and his choice to get a cup of coffee at the right time. We did also want to mention Dr. Ray Bridges is now the new Med Standards Chair, and he's not smiling as much as Dr. Marshall was when he left the room. Other issues, State Medical Director is going forward. Ryan had mentioned before, it looks like it's going to be a full-time position, and I think we'll get some qualified people applying for that. let's see, Al Lewis gave us a little information on EMS essential services is slowly moving forward, which I think is very important, and I guess he'll give a better report when we get the legislative later today. And with that, I'm going to turn it over to Dr. Raybridge to talk about the second motions from Med Standards.
Thank you. So Med Standards brought forth seconded motions regarding the protocols. The first was the collaborative ALS protocol update, which included the alternative medication formulary and hospice care protocols that was approved by the SEMAC. So we bring that here, those protocols. It's got to warm up.
It's warming up. It's a state projector.
Yeah. Basically, the motion is to approve the collaborative ALS protocol update. It's fading into view now.
And there was some discussion about effecting date, and they did make their motion say that it would follow the usual plan, even though this should have been voted on in December when we didn't have a quorum. It was voted. Yeah. It will be voted on here today, and if approved, will go in effect as planned July 1 this year.
Correct. So that is the motion for this group. Yep, for approval. If there's discussion on the ALS protocol update.
Hearing none, can we have a roll call vote?
Scott Clark.
Scott Clark, yes.
Dr. Krupe. Mark Devers.
Mark Devers, yes.
Don Duval.
Duval, yes.
Michelle Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Carl Gandolfo, yes.
Gregory Gill.
Gill, yes.
Jason Haig.
Jason Haig, yes.
Don Hudson.
Don Hudson, yes.
Dr. Isaacs.
Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Jared Cutson.
Jared Cutson, yes.
Al Lewis.
Al Lewis, yes.
William Masterton.
William Masterton, yes.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
Elizabeth McGowan, yes.
Mark Philippi.
Philippi, yes.
Marianne Portoro.
Marianne Portoro, yes.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener, yes.
Carla Simpson.
Carla Simpson, yes.
Christopher Smith.
Smith, yes.
Chad Smith.
Chad Smith, yes.
And David Violante.
Violante, yes.
Motion passes.
Thank you.
Thank you. The next motion was on the BLS protocol update. The same motion that be approved with the implementation date of July 1 as the ALS one was. So any discussion on the BLS protocol? All right, hearing none.
Scott Clark.
Scott Clark, yes.
Dr. Krupe.
Bob Krupe, yes.
Mark Devers.
Yes.
Don Duval.
Duval, yes.
Mickey Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Carl Gandolfo, yes.
Greg Gill.
Gill, yes.
Jason Haig.
Jason Haig, yes.
Don Hudson.
Hudson, yes.
Dr. Isaacs.
Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Jared Cutson.
Jared Cutson, yes.
Al Lewis.
Al Lewis, yes.
William Masterton.
William Masterton, yes.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
McGowan, yes.
Mark Philippi.
Philippi, yes.
Marianne Portoro.
Marianne Portoro, yes.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener, yes.
Carla Simpson.
Carla Simpson, yes.
Christopher Smith.
Chris Smith, yes.
Chad Smith.
Chad Smith, yes.
And Dave Violante.
Violante, yes.
Motion passes.
Thank you.
So just one thing on the BLS and ALS protocols, just a reminder that there is a change log that is there with them. We are trying to set that as a standard going forward so that people know what has changed, especially in a larger documents when it's not just one small protocol that's going up. That protocol change log will also be posted with the protocols, and I think it was said, but the protocols will go into effect on July 1st. That date has not changed.
Correct. And then the third forwarded, seconded motion was on the approval of the New York City protocol changes. That consisted of 3 protocols, anaphylaxis, emergency childbirth, and a vaccine protocol. Discussion on the New York City protocols.
Scott Clark.
Scott Clark, yes.
Dr. Krupe.
Bob Krupe, yes.
Mark Devers.
Mark Devers, yes.
Don Duval.
Duval, yes.
Mickey Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Carl Gandolfo, abstain.
Greg Gill.
Gill, yes.
Jason Haig.
Haig, yes.
Don Hudson.
Hudson also abstain.
Dr. Isaacs.
Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Jared Cutson.
Cutson, yes.
Al Lewis.
Al Lewis, yes.
William Masterton.
William Master, abstain.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
McGowan, yes.
Mark Philippi.
Philippi, yes.
Marianne Portoro.
Marion Portoro, yes.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener, yes.
Carla Simpson.
Kyla Simpson, yes.
Christopher Smith.
Chris Smith, yes.
Chad Smith.
Chad Smith, yes.
David Violante.
Violante, yes.
Motion passes.
Thank you.
The final action item we had was the forwarded suggestion from the Training and Ed Committee regarding the sunsetting of the EMTCC level, which, God, please don't ask me to read that. I can't see it that far away. But can you read it? You have it there?
I'll give you the bullet points of what you might be able or not be able to see up there. This is came up to both SEMSCO, SEMAC, and Training and Ed in December, but because there was not a SEMAC or Med Standards meeting, it was routed back to these 3 groups, and so here it is now, having gone through Training and Ed and through Med Standards and through CMAC, and basically describes the process for sunsetting the EMT critical care. The bullets are all expired EMT critical cares can continue to refresh at the AEMT level via the established processes indefinitely. The final EMT to CC to paramedic bridge shall commence April 2026 to coincide with the next bullet. The ALS collaborative protocols will remove the EMT CC level of care when implemented on the annual revision timeline July 1, 2027. And all currently certified New York State EMT CCs shall expire July 1, 2027. Not them, but their cards shall expire. And they will automatically be recertified at that time as AEMTs for the duration of their certification cycle. And then all ePCR platforms in use will reflect each previously certified EMTCC at their new level on July 1, 2027. And those were the proposals that went through the 3 committees so far.
Yep, so that came forwarded from Med Standards, and then CMAC both voted on that to approve that, and it's brought here for discussion.
Mr. Chairman, this is a subject that's been around for a while, I might add. We've talked about it a lot, and while I embrace 2027, I do it with concern. There's no doubt that we are short of tens of thousands of EMS workers. And these critical cares provide a lot of help for some of our agencies. Mostly, I think I can say in rural areas. And I think we're working on a plan to close the gap and bring them on board as paramedics But I just am cautioned to think that with the disastrous situation staffing is in across the state, we can't lose 2 of them or 3 of them and shut down an ambulance. That's a concern I have. So we need to monitor this very carefully. I'm hopeful that we get through this staffing crisis with a lot of help, and I believe the Bureau is on board 100% with this. But I can't tell you, I have to say this quite loudly, we can't fill the ambulances we have in some of our communities with trained people. So those ambulances are sitting idle until more people are trained to come into our businesses and our volunteer groups, and it's across the board. It's not just paid services that are experiencing this. So I caution us to be careful when we start to eliminate EMS people. Thank you very much.
Yeah, Don.
I was just going to, more procedural. So there's a seconded motion that'll come forth under training and ed that literally is verbatim. Are we handling all 3 at once? Or do we have to revote when this same exact motion comes up during training and ed's report?
We're lifting this from you, so it's one burden off your shoulders.
Thank you.
Happy to take the heat for you. Other discussion on this?
So Chad Smith from Mid-State Remsco. Not that I didn't know where I was from. Just wanted to make sure I spelled it right. So speaking from my region, I know we have several agencies that are reliant on critical cares for this, and I know that it's a good thing, it's a good move for the industry to sunset this and move them up to the paramedic level when they complete their training. It's good for the community paramedicine, it's good for everybody. But I mirror the concerns of the Southwest region of possibly looking at, instead of 2027, looking at 2030. One more cycle would help the agencies, would help the providers get just that much closer to becoming paramedics than stepping down to the AEMT level. I don't know if anybody else has that same concern or same idea, but that's my thoughts.
Thank you. Go ahead.
That's all good. I believe that we should embrace standards and levels of certification consistent with the national scopes of practice model. And I'm a firm believer in the AEMT as a mid-level. It would not hurt my feelings to see critical care completely sunsetted. However, as part of the original discussions, when we made the decision not to revamp the curriculum and continue investing in a level of care, we left an open-ended timeline. And some people had discussions with the last couple of nights, remembered, as I do, we purposely left that timeline open. In hindsight, it may not have been the smartest move to get everybody on board, but at the same time, it's a promise we made at the time, and I think we need to honor that promise and look at retiring the level through attrition as we originally planned.
Thank you. Other discussion? Don.
Thank you, Doc. So as chairman of the Training and Ed Committee, we didn't take this lightly. As has been said, this has been an ongoing discussion actively for quite some time, and then retrospectively for 7+ years now. None of us bring this to the table lightly. The impetus behind setting a date was to
give people, regions, agencies, and, ultimately serve our patients with a planned phase out. Having again been involved, as many of us were, in the initial discussions way back when about setting, talking about a sunset, the formulation of the bridge program, and everything that went into that up to date. Not making excuses for not setting a time frame back then, but I think there was a lot of trepidation, as there understandably would be today. The unknowns back then were, we really didn't know how many providers were in each region, who was active. Most of the state wasn't on ePCR at the time, or we weren't capturing any sort of data on any level that any of us could feel certain about where we were going, where we wanted to be. I would suggest to the group that we're in a much different place right now, and whether it was right or wrong not to set a date back then, I think it's time to set a date now and allow time, as proposed, 2027, 3 years from now, 3+ years from now, for regions and providers to plan. As training and ed chair, I will offer to any region, provider, agency, or otherwise to meet with them virtually. I'm not able to travel everywhere, but virtual is probably at least an initial option, and if that turns into an in-person appearance, that's fine. You're more than welcome to drive downstate to see me too. But that being said, whatever the hold-up, trepidation, misunderstanding, lack of information, bad information is that might be preventing somebody from bridging, that might be preventing an agency from embracing that, might be, preventing a SEMAC, a REMAC, or a REMSCO from looking at AEMT level of care. All of these things are rolled together to, formalize our system, and really move it ahead. Not to take anything away, but to add. And I think from training and ed's perspective, putting a date on this and giving people a plan to either move up or stabilize what has been a dying level of care for some time is a value added, not a value removed. So that being said, if anyone wants to meet or discuss bridge or anything else, I would just suggest to the group, I know not everyone makes all the meetings, but we did have a presentation from Allegheny County that initially in December's meeting voiced concern that, amongst other things, the example I would give is that people couldn't drive down to New York, down to Long Island in order to take the bridge program. And only in coming here, asking the question and challenging us, could we then explain to them that, well, the bridge is essentially online. You don't have to travel very much anywhere to do it. And the part of their presentation that's pertinent to the discussion is of their 12 or 14 current EMTCCs, since that discussion in November, they have all but 2 of them either in a bridge or formulating to get into the bridge to stabilize their system and push the level of care up, not down. So kudos to them. Thank you for coming to the table with the question initially, and I'm enamored by what you were able to pull off in the last 2 months. So there is a success here. We just have to embrace that. So thank you.
The letter from Southwestern that was read during communications, there was discussion about that this morning as well, and it seemed to me like a little bit of a change of heart. I wonder if I think it was Dr. Walters maybe, one of the docs from Southwest region sounded as though they were a little bit different in their position as well from when they drafted their letter. If anybody wants to speak on that.
Yeah, for the record, Dr. Walters voted in favor of this and did speak to it, so. Okay, I think we've had good discussion. Can we have a roll call vote?
Scott Clark.
Scott Clark, no.
Dr. Krupe.
Bob Krupe, yes.
Mark Devers.
Mark Devers, yes.
Don Duval.
Duval, no.
Mickey Fornes.
Mickey Fornes, no.
Carl Gandolfo.
Colgan Dalfo, yes.
Gregory Gill,
Gill, no.
Jason Haig,
Haig, yes.
Don Hudson,
Hudson, yes.
Dr. Isaacs,
Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Jared Cutson,
Cutson, yes.
Al Lewis,
No.
William Masterton,
William Masterton, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
McGowan, yes.
Mark Philippi,
Philippi, yes.
Marianne Portoro,
Marion Petoro, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Redlener, yes.
Carla Simpson,
Carlos Simpson, yes.
Christopher Smith,
Chris Smith, yes.
Chad Smith,
Chad Smith, no.
Dave Violante,
Violante, yes.
motion passes.
Thank you.
All right, thank you. So just on the protocols, as a reminder, the protocols now go through legal review and then be sent to the commissioner to make sure that everything's in alignment. For example, the vaccination protocol, if that comports with the requirements. And that'll be the next steps, and that concludes the Med Standards report.
Any questions for Med Standards? Before I jump over to Don for training and ed, I wanted to mention that Assembly Member Paulin, who is the highest ranking member of the Assembly Committee on Health, is here. And Assemblywoman, would you like to say a few words?
Thank you so much.
Thank you. Can you all hear me? I am the post-COVID health chair. I just have this committee for last year and this year with the retirement of Dick Gottfried, my good friend and mentor, and inherited post-COVID health issues, workforce shortage across the board. And of course, I would say this one stands out. Your service and your commitment to the community is so paramount to our success in healthcare. And I just want to thank you and appreciate your leadership and all that you do. And certainly, we're going to be taking the governor's proposal very seriously. Last year, we were able to achieve some things together. I was struck, however, in going through last year, and I don't know if it'll be the same, I do expect it will be, that there's really no agreement among you. There were groups opposing last year's changes, and yet there were groups within you supporting them. And that, I think, can't continue if we're going to make progress. Everyone has to respect their own local area. And I will say that the reason I came today is because my local area is on the table on one of your agenda items, and it's been delayed several times. And, we in our area need that change in order for our local EMS to be able to survive. So I wanted to understand the process by which those kinds of decisions, since with SEMSCO it was nearly unanimous support, how are those decisions made so it'll better help me understand helping you in the future, helping everyone in the future, helping the rural EMS who are having a workforce shortage and a location shortage, right? It's the distances are ridiculously far, and yet you want the response times to be the same as you would in a suburban or urban area. So we need to we have a lot of work to do together. I look forward to it, and I look forward to hearing all about the discussions going forward. And I plan on following it much more closely because of the dire need that we have. Thank you.
Thank you so much.
For those of you who don't know as well, Assemblymember Poland, the community paramedicine bill that came through last year was one of the initiatives that she had forwarded in that front and has helped kind of really move us forward in knowing a lot of the work, not only her, but her entire office. Mark is here as well. But, just being able to have that, and I think we're seeing more and more of EMS is, it's in crisis, we have our problems, but it's also being recognized, and I think this just has a lot on that recognition of where we are advancing and working to, correct the system in many different ways. So thank you also for joining us today, both of you.
Don Hudson.
So I'll take a moment, if I may, before I give my education report to the legislative members that we now have in presence, to the deputy commissioners that we have their attention. I haven't been here as long as some, but I would suggest to this group that we're in a position now that I don't know we've ever found ourselves. So everyone's talking about EMS, not just us. We see the people in this room continue to grow, which was not always the case. I don't know what viewership at home is like, but I would hope that too is on the rise, either live or recorded. What I'm suggesting is now's the time, if ever, to do the things that we continue to talk about and debate. And we're not going to have unanimous agreement on anything. I don't know that we should. We want that conscientious dissension at times, especially to spark debate. But I guess to our legislative counterparts, I would ask for your help and guidance in helping us navigate a world that is completely alien to me, which is how the government works and what the processes are to get things done. And I understand that might be a whole lifetime to understand, if ever, but I want to say that because I'm sure I'm not alone in the room. So as we need the governor's help, as we want to provide guidance to our commissioners of health and partner with the people that represent the patients we serve, our legislative counterparts, it truly is a combined effort. So enough about me. Let's talk about you. So the motion to allow, I guess we have two forwarded motions coming forth. And I'm not going to be able to read that either. Can one of the... Oh, yeah. I know what it says, but I don't want to...
Motion to allow the use of calculators on all New York State EMS certification exams.
So that's a short one. It mimics what the National Registry has done on their exams some time ago. So it's, again, sort of leveling the playing field.
Because this is statutory and your next motion, Psychic Hotline says, is also statutory, could we bundle those unless someone finds this controversial?
As I am naive in the ways of how things are supposed to be done, I will take your advisement and combine them gladly.
Mike, just to clarify in this motion, it's not bring their own calculator. It'll be on the PSI when you take the exam, like the National Registry for the folks outside.
DOH would tell the testing vendor to turn on a calculator on the screen for the student.
So then, Mr. Chair, do you want to read the other motion and we'll joint vote on them?
Yeah. Beth, you may have to read this one too.
Effective July 1st, 2024, to allow any COAMPS accredited paramedic program to substitute in-course student skills evaluations and COAMPS student skill portfolios in place of a formal 1 or 2 day practical skills exam for paramedic original students.
And thank you to Ms. Gow for being the reader. This also is sort of tied, well, not sort of, it's tied to the cessation of National Registry Practical Skills exam and the continuing discussion of what impact that'll have on, in this case, paramedic original education, which is the easiest of the lifts, and then what that impact will be in further discussions to the other levels of care.
Any discussion on either of these motions, calculators or practical in the paramedic original?
Mr. Chair, if I may, Jason Haig, just curious about PSI with the turning on of the calculator option. I know there was a surprise increase a few months ago. Just want to make sure this isn't going to cause another surprise increase for the testing fee for PSI.
Is Drew here? Drew says, "Bleh."
Chief Chesney, come on up. I didn't even get to hear it, so now you really get to send it.
Will putting calculators on increase the price of the exam for the students?
I'm good. While I don't have a definitive on that, I've already communicated with PSI on this possibility, and it was not one of the items brought up. And as Ryan and I would say to them, they owe us a couple favors, so I don't assume this will be an issue.
It's the answer I was hoping for. Thank you.
Perhaps
We've
it's an
traded
opportunity.
several ticket complaint numbers for the calculator. Thank you to all of you who participated.
Perhaps it's an opportunity to remind PSI they might have charged us to turn it off.
Any other discussion on either of the motions? If not, we'll have a roll call vote. They're both statutory.
Okay. Scott Clark.
Scott Clark, yes.
Dr. Krupe.
Bob Krupe, yes.
Mark Devers.
Mark Devers, yes.
Don Duval.
Duval, yes.
Mickey Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Carl Gandolfo, yes.
Greg Gill.
Gill, yes.
Jason Haig.
Jason Haig, yes.
Don Hudson.
Hudson, yes.
Dr. Isaacs.
Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Jared Cutson.
Jared Cutson, yes.
Al Lewis.
Al Lewis, yes.
William Masterton.
William Aston, yes.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
McGowan, yes.
Mark Philippi.
Philippi, yes.
Marianne Portoro.
Marianne Portoro, yes.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener, yes.
Carla Simpson.
Carla Simpson, yes.
Christopher Smith.
Chris Smith, yes.
Chad Smith.
Chad Smith, yes.
David Violante.
Violante, yes.
Motion passes.
Thank you.
That's the end of my report, Mr. Chairman.
Any questions for T&E? If not, this is where I'm going to jump things around. Mr. Lewis, if you could give the legislative report as that needs to go before finance.
Thank you, Mr. Chairman. I would be glad to. We're going to tag team this. Mr. Kroll is going to talk about the initiatives we would like to see this committee pass for legislation. First of all, I want to start by a special thank you to Governor Hochul for supporting EMS. Last year and this year, her support is unparalleled, and we can't say enough how much we appreciate all she's done, and it moves EMS in the right direction. So the committee has several motions, and Steve is going to work all of these, and I appreciate his help with it. Mr. Kroll.
The committee is bringing forward 5 motions, and we'll do them one at a time. I don't believe they require a roll call vote, so we can, do them by voice vote. The first one refers to something that Director Greenberg already discussed. To support needed growth in the EMS workforce, the Legislative Subcommittee asks SEMSCO to recommend to the Bureau of EMS that training funds be used to support and pay for the paramedic training of a number of paramedics equal to the number that are going to be hired by New York State to staff the new EMS task force.
Any discussion on that motion? If not, all in favor signify by raising your hand.
Aye.
Any opposed, same sign. Any abstentions? Motion carries.
The second motion that will be up on the screen, I'm going to read the original motion that was passed as a seconded motion, and then I'm going to ask the chair to allow me to make an amendment to the motion. In some discussions earlier today, we felt some clarifying language that doesn't affect the substance of the motion, but affects the how it reads was important to do. So the original motion is that the Legislative Subcommittee recommends that SEMSCO endorse Senate Bill 5000 by Senator May and Assembly Bill 4077 by Assemblymember Lupardo that will remove EMS services from the real property tax cap to reduce barriers to EMS funding. The change that I'm going to move we make in his amendment is going to be that we change it to the Legislative Subcommittee recommend that SEMSCO communicate to the Commissioner of Health support for these bills. So we're really just modifying the language of how we're expressing our support to be more closely aligned with the way it should be written as an advisory body to the Commissioner of Health. And I think, so that would be, and we're going to make that same change in all four motions, communicate to the Commissioner of Health support for, in lieu of the word endorse.
Any discussion on this motion?
Does that then require a second?
It would,
I
because
second
it's
it.
amended motion.
I second the amendment. Hudson.
Second to the amended, or second to the amended motion by Don Hudson. Any discussion? If not, all in favor signify by raising your hand. Any opposed, the same sign. Any abstentions? Motion carries.
The third motion, the Legislative Subcommittee recommends that SEMSCO endorse S8486 by Senator Hinchey that would establish a mechanism within the Medicaid fee schedule to provide a reimbursement to EMS agencies and telemedicine providers for treatment in place and transport to alternate destinations. And then again, I'm going to make the motion move that we amend the motion to the SEMSCO communicate to the Commissioner of Health support for.
I'll second that a motion.
Any discussion on this motion? If not, all in favor signify by raising your hand. Any opposed, same sign. Any abstentions? Motion carries.
I'm going to move to the fourth motion now, and I do want to mention that there's a common theme of all of these bills. These bills were part of the package that was discussed at the press conference last week that many of our legislators held, and I think many have seen that lots of us were all in the same place with a lot of senators, assembly members, and they have put together, and reinforcing what Al said, they put together a whole package of legislation that's being moved forward this year that supports us in EMS. So the fourth motion, the Legislative Subcommittee recommends that SEMSCO endorse S6630 by Senator Mannion and A6274 by Assemblymember Barrett that allows volunteer firefighters and ambulance workers to claim both the state income and local property tax credits. And then again, I move to amend that motion to read that SEMSCO communicate to the Commissioner of Health support for these bills.
Second by Mike Masterson, or William Masterson. Any discussion on this motion? If not, all in favor signify by raising your hand. Any opposed, same sign. Any abstentions? Motion carries.
The final motion, it reads, the Legislative Subcommittee recommends that SEMSCO endorse S7286 by Senator Martinez and A7524 by Assemblymember Thiele that increases the volunteer firefighters and ambulance workers' personal income tax credit from $200 to $800 for eligible individuals. And again, amended to read that SEMSCO communicate to the Commissioner of Health support for.
Second to that change by Mark Philippi. Any discussion on this motion? Hearing none, all in favor signify by raising your hand. Any opposed, the same sign. Any abstentions? That motion passes. And for the record, all motions were unanimously approved.
Thank you, Mr. Kroll. Let me share with you now the items that were supported by the Legislative Committee. EMS as essential services is in the works, and we have lots of hopes that a workable legislative initiative will be passed, and this committee supported essential services. Treatment in place and transport to alternate destinations are very, very important, and I'll mention why for just a minute. As I said, 1 out of 3 ambulance requests by 911 are often not transported. Some of those are people with diabetics that are awakened with medications and they refuse treatment, which is kind of usual now, and somebody that's overdosed with drugs that have been converted by medications, and they too don't want transport to hospitals. These transports and the care provided and time committed are not paid for. This bill that we have before the state will permit ambulance service, all ambulance services that charge for this type of care can bill Medicaid for this service. So I hope you all support it. Next one is the committee embraces the healthcare collaborative to improve models in the region. Community paramedicine, I believe, will play an important role in this initiative. The committee supports the expanded definition of EMS, more in line with what EMS does every day in every community across the state. We also support the concept of the 5 EMS zones, and we are hopeful the legislature will add new EMS funds in the final budget, along with a statewide focus on training for new EMTs and paramedics to stabilize EMS before the state hires the 80 paramedics. We support county-operated EMS programs that are needed across the county. We hope these programs are partnering with existing services and not pushing them out to capture more market share. I'll talk about the EMS grants for just a minute, if I could. So there's 10, Mr. Director, if I could. So there's 10 grants that have been funded by the budget, and they're about to be released for people, to counties to apply for. Is that correct?
You're talking about the county grants, the $5 million?
Yes, yes.
It's $5 million for up to $500,000 for 10 counties.
If some of these counties already applied, or is this something that will start?
The RFP hasn't gone out yet. So the RFP is in final draft position, then we'll go out and come back based on need and the scoring mechanism and then determination.
All right, thank you. The only other thing I would ask is, I mentioned it earlier, is I believe we need to do more PSAs. I don't think everybody knows that EMS is in a disastrous situation. We need PSAs, we need Facebook, we need TV ads. We need more people to know that we need more people. We are in crisis, and the more we share that we need them may help us get those people to step forward and want to be EMTs and paramedics. And that's the end of my report, sir. Thank you very much.
Thank you. Any questions for legislative and or finance? I believe that's your finance report also, Mr. Kroll, correct?
I do have some additional things from finance. No motions, but some discussion.
Okay.
We discussed between finance and legislative a lot of the things that were that you heard about. I also want to mention a few of the other things we did. First, we recognize and discussed at our meeting that there's something that was not in the proposals that we just talked about. One of them, and that is that we continue to be paid far less than it costs to deliver services by the Medicaid program. and that we were disappointed that there was not anything in the budget that would change the Medicaid rates this year. As you know, Medicaid makes up statewide somewhere around 1/3 of the ambulance service call volume, and we are paid substantially less than our costs for that 1/3 of the calls, even with the things that were in the budget last year, for which we are quite grateful for the increases that were in there last year. But we are hoping that there will be some further increases. Assemblymember Hevesy from New York City has told us that he intends to introduce legislation that will bring about an increase in the Medicaid rates, and we are colloquially calling it Get Us to Medicare. You know, the Medicaid rate should be brought up to the Medicare rates. It was pointed out by Mr. Call yesterday that still doesn't get us to our costs, but if they were to get us to the Medicare rate over a period of 3 years, that would be a really great step forward. So we're pushing forward that conversation. I also want to mention that we discussed the rural grant funding available from the federal government, and that is the Siren Grant Program. I did send something out on Boardable to all the SEMAC and SEMSCO members about this, and I ask you to share this back in your regions because we're on a schedule now. There is going to be somewhere around $30 million available in this next federal fiscal year for grants to rural emergency medical services through the Substance Abuse and Mental Health Services Administration. These grants will cover a 2-year period at a maximum amount of $400,000. These can cover recruiting personnel, training and education, personing and equipment and supplies. It is related to substance abuse, but not exclusively substance abuse. In other words, if you are, it is in the interest of the Federal Substance Abuse and Mental Health Administration that rural ambulance services have robust capacity to respond, have the workforce to respond. So I realize this does not matter in every single region of the state, but in regions of the state with rural providers that are defined as rural, the amount of money the federal government's putting into this is triple what it was in the last grant cycle. So it's going from about 10 million to about 31 million. That means a lot of ambulance agencies can get this money, and the grants are due on March 20th. So if you have rural providers in your region, I encourage you to let them know about the grant funding that's available. Groups like the American Ambulance Association and the National Association of EMTs, and probably also the IAFF, have been doing seminars on helping members to be able to apply for these grants, so I think it's an important resource. Director Greenberg already discussed the education funding a little bit, and so I want to emphasize that we were reported to at the Finance Committee that we're about $2 million short. No, I'm sorry, that's not the right term. There's going to be about $2 million left in the budget on educational spending this year. So in his report, he already discussed some of the things that we can do. For example, he discussed how we can have more academy-style classes and how he's thinking about with the team ways to do that. He also discussed that, the motion that was made coming earlier about the ability of us to provide some more training dollars to paramedic students to get them from ENT and paramedic for each of the people that are being hired into the EMS task force. But I think it's important for everyone to take back to the REMSCOs and the REMACs or to their county meetings or when the core sponsors get together. There's money out there that's not being vouched for, it's not getting used. We have done a great job as a finance committee pushing forward and asking for there to be more funds in that budget. And the answer back is, as soon as you spend all that money, we can talk about giving you more. So I think the director and the Bureau staff are trying to do things, and we can give them more suggestions on what to do, not just the ones that we already have, so that they can find ways to make sure that money gets spent. But it's also incumbent on us in the field to get that money spent, right? We have to in our local regions. And so one of the discussions yesterday was there is a shortage of CICs, and maybe we want to teach more classes, we need more CICs. The suggestion that was made about that is, what if these task force paramedics also become CICs and are able to, as part of their responsibility, or maybe they become CLIs, and they can assist in teaching. So it's a partnership of shared responsibility. The Bureau can do what it can, but we, all of us, and all of the people back in our communities have to come up with ways to spend this money. The best thing that can happen to the Finance Committee is in May, or rather in September, whenever we meet, we hear that we're on pace to run out of money because we used it all. Then we can go and ask for more training money. So that's my pitch on that. The committee has been asked to have next year's budget recommendations done, not at the December meeting, but by earlier. We're going to try and wrap it up in August because we've been told basically that is when the Department of Health is required to submit their stuff to the Bureau, to the budget folks inside the Department of Health that send in the requests. So we've been doing a good job of getting our job done, but we got to get it done earlier. And I think that concludes my report, and thank you.
Yeah, can I just make a brief statement about Krupe, okay, New York City, SEMSCO? And my statement is actually, Brian, to thank you for your comments earlier regarding the budget, again, working with us to address the program agencies, regional EMS councils. And I think Steve was very eloquent in his laying out what we need to be thinking about. But speaking for myself, as a SEMSCO member, and I think the Finance Committee would agree, and feel free to speak up if you don't. We want to really acknowledge the work done by Director Greenberg and the Bureau of EMS to really support an increase in funding for program agencies and regional EMS councils. Although the proposed governor's budget currently has no increase in funding for program agencies, we do understand the Bureau is working to ensure some additional funding that will be available provided during the new contract period beginning July 1st of 2024. So we thank you for help with that. We ask the Bureau to continue to support the program agencies of New York State and work with the SEMSCO Finance Committee, which I know you do want to do, but provide us with all the financial information possible so we can fiscally make accurate recommendations to be provided to the commissioner and also to the governor. We've not had, the program agencies in New York State have not received an increase in funding since 1997. Okay, that's a very long time. So the modernization of this state's EMS really must include appropriate funding for the expansion of 21st century regional EMS administration and oversight. I know we can work together on this. Okay, please, keep us involved, share information. Okay, so we can share our inputs with you, so we make sure that we help each other, get the funding that we all agree we need.
Thanks. Just to follow what Dr. Krupe said, I definitely want to acknowledge here that the program agencies worked very closely with the Finance Committee to provide justification that explained how their role has changed over the last 2 decades, how their engagement and the response, the resources they've had to bring to bear to do their jobs have increased. And so that's part of the work the Finance Committee has done to provide to the Department of Health. And I think I agree with, with Dr. Krupe that we have sort of an incomplete in this area as a Finance Committee, as a SEMSCO, because we're in the middle of a contracting cycle. We're hoping that contracting cycle, when the contracts get removed, bears out the fruits of just what Dr. Krupe was talking about.
Thank you. Let me move on to sandwiched in between these last 2 reports, Mark Devers and EMS Systems.
Mr. Chairman?
Go ahead.
I'd just like to add one thing to Committee Chair Steve Kroll. Thank you for the great work on the Finance Committees, Mr. Kroll. I just wanted to add maybe one word to the matching of Medicaid reimbursement to that of Medicare, adding the word prevailing Medicare. Because, as you know, that's a moving target. And so, while we're asking, I recommend keeping current. Thank you.
Thank you.
Good afternoon. I will attempt to keep this brief. I have one seconded motion. I guess I have to read more words. In accordance with Public Officers Law, Article 474 Code of Ethics rule with respects to conflicts of interest, no officer or employee of a state agency, member of a legislature or legislative employee should have any interest, financial or otherwise, direct or indirect, or engage in any business or transaction or professional activity or incur any obligation of any nature which is in substantial conflict with the proper discharge of his duties in the public interest. For the purpose of this meeting, interest shall include any interest, financial or otherwise, whether as owner, officer, director, fiduciary, employee, consultant, or supplier of goods or services in any agency or organization. Any member who has an interest in an agency or organization that is subject of an application under Article 30 of the Public Health Law that is or will be before the council for consideration or determination shall identify such interest to the council or committee at any meeting when the application is to be considered, refrain from discussing such application with any member of the council or department of health staff at any time prior to or at any council or committee meeting when the application is being considered, shall absent themselves from any portion of the meeting when such application is being considered, and shall not participate in any vote of the council or committee on the application or complaint. So in respect to the Bay Community Volunteer Ambulance Corps CON appeal, is there any members who need to declare a conflict at this time?
Mr. Chairperson, Jerry Gelbard, although I'm not a fiduciary or pecuniary, my entity is collaterally mentioned in the recommendation. Therefore, I'll recuse myself from the matter.
I would also need to recuse myself as medical director, Kiki, of the Bayside, the Glen Oaks Volunteer Ambulance Corps.
All right, so in the matter of the Bay Community Volunteer Ambulance Corps application of March 21st, 2021, on an appeal of the determination of the New York City SEMSCO's denial of the application was made by Bay Community Ambulance Corps. The public hearing was held on May 21st, 2021 via Zoom. Hearing officer's report dated June 23rd, 2021 finding was that the determination of need was met and recommendation to approve from Timothy Hannigan, Esquire. At the SEMSCO meeting on July 21st, 2021, the application was denied. Bay Community Volunteer Ambulance Corps appealed this decision on August 10th. On July 29th, 2022, Sean O'Brien, the ALJ recommends the decision of the SEMSCO be upheld. On December 7th, 2022, this body voted to uphold the SEMSCO's decision. An appeal was filed in Queens County Court on April 5th of 2023. Stipulation and discontinuation of proposed order from Queens Supreme Court signed by the Honorable Joseph Esposito is dated September 26, 2023, and it remands the decision back to ALJ and this body. The ALJ report dated November 13th, 2023 by John Turpka states, and I've got to pull that up real quick. The July 29th, 2022 report and recommendation of ALJ O'Brien to the SEMSCO should be amended to reflect that there was a need at the time for additional EMS in Bayside. The report and recommendation should be further amended, however, to also include the finding that since the SEMSCO hearing officer and ALJ O'Brien's report were made, Glen Oaks has received SEMSCO approval for its expansion into Bayside on the application made before Bay Community's application. The applicant herein has not met its burden of proving that there continues to be public need in Bayside. The SEMSCO should review and consider the finding in making the determination whether to deny or grant the application. The ALJ's report and recommendation should otherwise be unchanged. So, the seconded motion coming out of Systems Committee is resolved to uphold the July 21st, 2021 determination of the New York City Regional Emergency Medical Services Council, which denied the Bay Community Volunteer Ambulance Corps application for the expansion of ambulance service primary operating territory. So, need a roll call.
So is there any discussion on this motion? If none, the decision of the Systems Committee was what?
To uphold the July 21st, 2021 determination of the New York City SEMSCO, which denied the Bay Community Volunteer Ambulance Corps application for expansion.
And that's the seconded motion that comes forward.
That is the seconded motion.
So if there's no discussion, we can take a roll call vote on this.
Scott Clark.
Scott Clark, yes.
Mark Devers.
Mark Devers, yes.
Don Duval.
Duval, yes.
Mickey Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Gandolfo, yes.
Greg Gill.
Gill, yes.
Jason Haig.
Haig, yes.
Don Hudson.
Hudson abstain.
Dr. Isaacs.
Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Jared Cutzen.
Cutzen, yes.
Al Lewis.
Al Lewis, yes.
William Masterton.
William Maston, yes.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
McGowan, yes.
Mark Philippi.
Philippi, yes.
Marianne Portoro.
Marion Petoro, yes.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener abstain.
Carla Simpson.
Carlos Simpson, yes.
Christopher Smith.
Chris Smith, yes.
Chad Smith.
Chad Smith, yes.
And David Violante.
Violante, yes.
Motion passes.
Thank you. Do you have?
Other than that, the highlight, the definition of need seems to be our stumbling block in getting a solid new guidance document with a good definition of need. I really think could alleviate a lot of these roll call votes coming out of my subcommittee. So, if you do have a draft of the definition of need, and if not already put it in the Google form, please shoot it to me in an email, text it, make it into a paper airplane. I don't really care. Because, any idea we can have so we as a committee can work towards tightening up 0606 would be awesome.
Mr. Chairman,
Go ahead.
Mark Philippi, for Mr. Devers on that last moment, item on the definition of need, my parting shot here as I leave the group. But I would ask the Deputy Director or anyone from the Bureau, what does SEMSCO have in this regard? Because as I've done some internet searches, and I wanted to participate in that survey, but I found myself stymied by the fact that there doesn't seem to be any consistent language that I can find from any state in the union that really addresses this issue. There's certainly some language in certain areas. For example, the Commonwealth of Kentucky has a very interesting way of doing it. They kind of put it off by saying EMS operating authority will be granted based on need as determined by the state's comprehensive EMS plan, which would be great if we had a comprehensive EMS plan. But also the Commonwealth of Massachusetts has something completely different and actually goes very, very strictly along determinations based on a lot of math. So I'm wondering if the Bureau might, or through the SEMSCO, have some resources that can help inform this.
So I'll speak, and I'll go back to some work Mr. Lewis and me and Mr. McAvoy did like 100 years ago, the last time this tag came up. And I wasn't in this role, I was in a different role. And there was a pretty exhaustive search for what other states had done. Yeah. And it resulted in nothing. The only consistent thing we could find is inconsistency.
So saying I'm in good company then.
Yes,
okay,
I'm validating what you found. So I would say from the standpoint of EMS, and we have asked SEMSCO at various meetings when we've been there, and There just isn't consistency among states. But that shouldn't stop New York State from developing a really good definition as the model for the country. It wouldn't be the first time we did something that was a model across the country, and maybe we should take up that torch and create that good definition that other states across the country could use. And, you know, I think we may need to get out of our box of looking just at the EMS perspective and take a look at how different states apply CONs or determinations of need as it relates to hospital systems, because that is much more clearly defined in a lot of state statutes. So we may want to start looking at other healthcare provider sectors to see what crossovers we can borrow.
And that's where we go down the rabbit hole of numbers, which may be the answer, but again, that's because there are multiple factors that involve building multi-million-dollar hospital services within a community that do differ from our model, but point well taken.
A lot of them are built on community needs assessments, though. So I think your reference to a comprehensive plan, that's why we need to get to one of those plans.
If I could comment, we did, and I think Rich was involved with that search when we did it across many states, and I think we found we do a better job of it than they do, because it's almost a rubber stamp on some of these things. And you know, people should not look at CONs negatively. They should look at them as balancing systems. And I believe the CON for EMS is meant to help balance the system, not overloading it. Because if you overload it, what happens? One company's running the other out of business, and all these things are happening, and you get too many systems in a given area, and the paramedics and EMTs don't get the opportunity to use their skills. So it's a balancing system, whatever we do. So we looked at that, and I don't know if Rich has a lot of information. He may still have what we looked at. Thank you. Yeah.
Andrew, Noel, Systems. Or, excuse me, Safety.
Safety. Thank you, Chairman. I'll be brief. We have finished our policy 0013 policy model update. We'll take one more go at it as a committee and then get it off to the department for review. Continue to work on our provider resiliency project. We'll have an update in our next meeting. Our management of escalation tactics has hit a brief pause as there was an incident in Rochester that the DOH is reviewing, and we expect some more information to come on that will help give us better guidance on how to proceed. We are continuing to work on our, at the time was called Hazardous Response Plan that Carol Baranzo overseeing. We have now renamed it to the All Hazards Event Work Group. We have identified the stakeholders for engagement in the future with the county emergency managers, and then we'll continue to work on that and have a larger update for our May meeting. Still working on the reduction of lights and sirens, and then Director Greenberg gave us a Part 800 reg update earlier in the meeting, and then we will begin to review the sustainability paper for any sort of safety initiatives that are in there and start to work on those and bring those back to the SEMSCO.
Thank you. Any questions for Safety? If not, we'll move along to Dave Violante and the quality metrics.
Thank you, Mr. Chair. Just from an activity report perspective, we're working on our webpage to update it with data dictionary, posting all of the measures to the site with links to resources, adding links to agencies wherein some of this data comes from and processes come from. We're continually working on policy tag number 1202, 1203, 2104 on the definitions of patient and patient contact, and moving that towards regulation. We are looking at grants updates and working with AHRQ grants on two levels. Initially, pilot demonstrating project to train individuals across the state. Then a larger project of data collection and a dashboard really working to look at a sustainable infrastructure to do QI and quality outcome measures. We are looking at the idea of a quality certification for an individual at an agency, looking at the SEMSCO pillars of certification, leadership and quality, accreditation programs of the state, building a CME portfolio of QI items, and a couple of levels that potentially basic and advanced level. Ryan Greenberg talked quite a bit about how we happen to fall into other areas of interest in the state in terms of assisting in quality improvement, and we're very happy to and look forward to working with our chiefs to that end. Other items that we are looking at are opportunities for program agencies and REMSCOs to assist them, doing training and education around the state, including quality metrics videos, and potentially state-run courses that could qualify for state funding, very much like a CLI course. We are looking at the data across the state, and Ryan Greenberg talked about NEMSIS 3.5 and their rollouts. The state has provided good feedback sessions around the state that were very, very helpful in creating dialogue, communications, answering questions, and that we need to do some more of those things. And the data informatics team anticipates that we will be able to move towards 3.5 pretty effectively, so we're encouraged by that. We believe that that is where we are, unless there's any questions for us.
Any questions for quality? If not, we'll move on to EMS innovations and research. So Michael Redlener has taken over for Jason Haig as the chair of that committee. So Dr. Redlener.
Thanks, Dr. McAvoy. Thank you for the opportunity to serve in this position. We used yesterday's meeting in innovations and research to really broaden the conversation around areas where we need to think about and discuss the things that are happening in EMS today. And so I'll bring forward one forwarded motion from the committee, a seconded motion from the committee, and 3 areas just to specifically mention. So the forwarded motion is in the area of behavioral health. As folks in the room may or may not know, last year in Chapter 57 of Public Health Laws, the Daniels Law Task Force was established in order to identify potential operational and financial needs to support trauma-informed community and public health-based crisis response and diversion for anyone in the state experiencing a mental health, alcohol use, or substance use crisis. So the task force has been given the task to identify opportunities to develop innovative programs. Mr. Mark Devers serves as the representative for SEMSCO and brought forward to the Innovations Committee a concern that the EMS voice needed to be heard through this body in official communication to the Daniels Law Task Force to ensure that the EMS voice is included in the results of the task force's recommendations. So the seconded motion for approval, it goes as such. So that the draft letter on boardable titled "The Draft Letter to Daniels Day Task Force" be officially sent by the SEMSCO chair to the Daniels Law Task Force for consideration in the development of the task force recommendations.
Any discussion on this motion?
Mr. Chair.
Go ahead, Mark.
Can I ask that we amend the, my eyes aren't good enough to completely read it, but to add in there somewhere to direct the chair to send a letter to the Daniels Law Task Force?
I think it is added in there. It is.
What did I?
You have failed the vision test.
Yeah.
Any other discussion? If not, all in favor of that motion signify by raising your hand. Any opposed? Same sign. Any abstentions? All right, carries unanimously.
Thank you, Mr. Chair. The second aspect of the behavioral health innovations that we wanted to just articulate from the meeting discussion was that we are in support of the idea of collaborating with the Office of Mental Health to ensure that the work that they're doing there is works with the EMS systems in New York State, and that specifically consider, assigning EMS destination codes to the crisis centers that are being brought online by the Office of Mental Health to support alternative destinations. So it's not a forwarded motion, but something that the committee asks that we work on. In light of a lot of the discussion from previous committees' reports, there are a lot of opportunities in the legislative and budget work that's been done to further discuss and describe what community paramedicine and mobile integrated health programs will look like moving forward. And so we recommend that we start to think about what those program parameters are in conjunction with the Bureau, in conjunction with the other committees of SEMSCO, in order to start to think about what that should look like moving forward. The other aspects of that are as well to look at the barriers to implementation of programs. So ensuring that we understand what the barriers in the community are and barriers with our providers are. And the third aspect of the committee's discussion is around the conversation about essential services. And there was some support for developing a work group to identify opportunities to kind of get ahead of what, support the counties in looking at the ways in which EMS can be developed in their communities. So working together with SEMAC and with other groups to make sure that the guidance is there, and obviously support the Bureau in moving this forward. Then there was some discussion about innovations in education, and as well, kind of a beginning discussion about what does it mean to have a research committee at this level, and what can we do to support research in EMS to improve the science and the delivery of EMS. That concludes my report.
Any questions for innovation and research? If not, Dr. Rabich, did you want to talk about the DEI tag?
Sure. Did you want to start, Dr. Kutz?
Sure. So Jared Cutson, we've and thanks to Alex in the Bureau for pulling together the survey data. We had the DEI survey through the technical advisory group that we implemented through the latter part, fourth quarter really of last year. And Alex was able to pull all that data together. We'll be sharing that at the next SEMSCO meeting. We had 450 or so responses to the survey, and really from all across the state, which was nice to see. Of course, we would have liked to have a higher response rate, but we'll go into the details at the next SEMSCO meeting. We're going to pull the technical advisory group back together to help write up a report on what the data shows. And then next steps, I'll turn over to Dr. Rabich to talk about sort of the next steps for the DEI advisory group.
Thank you. Yes. So in addition to that report, the next steps for the DEI committee is we're focused on looking at implicit biases and how that may affect patient care in the state, whether it's use of pain medication or other treatment protocols among different patient groups, and how that may differ. And we plan to work with both quality metrics and innovations and research to put together some data along those lines and see perhaps some projects we may be able to design around that to bring awareness to where we may be falling short in our delivery of pre-hospital care to certain patient populations. And that's our report.
Thank you. Any questions for DEI? Is Amy Eisenhower here? Do you want to talk about EMSC? Dr. Cooper had to return to the city.
Hi, everybody. Amy Eisenhower, EMS for Children Program Manager. So our last meeting was last Thursday. And as Dr. Cooper mentioned, we talked about the Always Ready for Children Emergency Department Pediatric Recognition Program. And so for all the physicians in the room that work in an ER, we'd love to have you. It's related to pediatric preparedness in the ER, much like all of our programming. And it opened in June, so we do have 7 applicants. I'm hoping for many, many more. I am excited. I talked to Mickey and some other members of the ENA, so I'll be chatting with them at their conference in April about pediatric readiness. So that is very exciting. We also still have the pre-hospital pediatric emergency care program available for EMS providers to join. We have about 250 programs across the state at different agencies and about 300 pre-hospital PECs. So that's exciting, and of course, we'd still love to have more. So if you have questions about those, you can always reach out to me. We also talked about, Dr. Vanderyak discussed procedural sedation in the emergency department. And so there was some discussion on if we wanted to look at that further. Some of that is included in the pediatric readiness components for emergency departments and hospitals at the larger EMSC level. So there is some interest in that, and we're going to discuss that again in our next meeting. We had a report from our Pediatric Agitation Education Work Group, headed by Sharon Chiumento, and Chief Pataki from FDNY has been a great resource, and FDNY has been a great support for that. And they are currently working on scripting for 3 different scenarios for EMS providers to be able to see how does de-escalation work in some different situations. So that's excellent. And recently, about a week ago actually, I got the copy back from Public Affairs Group on an infographic with some tips on pediatric agitation. So my hope is that will be printed and will be available for use by EMS providers and emergency departments across the state shortly. The EMS for Children EMS survey will be coming up. I know that Ryan mentioned it. That'll be deployed in May. So we did talk about that. It has changed a little bit. So this survey is a little bit longer to take, but it also has more components on pediatric readiness. So my hope is that I will develop some guidance in conjunction with the other EMS for Children programs in the Northeast so that EMS agencies have a guide to go through it so they can complete it and make their life and my life a little bit easier. And we'll still get the data to the EDC. Our next meeting will be right here in this room on May 6th. Does anybody have any questions? All right. Well, thank you very much.
Thank you. We don't really have anything to bring forward from STAC, but I think we probably will soon have a STAC member here, which is good. You had one hint earlier today about some motions that are sitting on the table. I put a more overt hint in the agenda under old business. So if anyone would like to take things off the table, we could do that.
Yeah, I'd like to make a motion to take the Scarsdale vac and the Ossining vac motions off the table, please.
So we have a motion to remove from the table the Scarsdale determination of need appeal and the Ossining determination of need appeal. Second?
Second.
Take a second from Mickey Fornes. All in favor, signify by raising your hand. Any opposed, the same sign. Any abstentions?
I will abstain, Mr. Chairman.
All right. So it's unanimous with one abstention. Mr. Systems, do you want to deal with the Scarsdale one first? I'm not sure that you need to reread the the public officers law, but you could remind people of that and see if there's anyone who wishes to announce a conflict.
So does anybody need to repeat the public officers law? And if not, does anybody need to declare a conflict for
Miss-
Scarsdale?
Mr. Chairman, there is a perception that I am conflicted. With that said, I will leave the room while this vote takes place.
Thank you, Mr. Lewis.
Any others? Do you want to read the motion that we just pulled off the table? Oh, no, you failed the vision test earlier. We're gonna- Beth,
Resolved to uphold the February 2023 determination of the Westchester Regional Emergency Medical Services Council, which approved the Scarsdale Volunteer Ambulance Corps application for the expansion of ambulance service primary operating territory.
So that's the motion. Is there any discussion?
hearing none, we could take a roll call vote on this.
Scott Clark.
Scott Clark, yes.
Am I okay? All right, Dr. Krupe.
Bob Krupe, yes.
Mark Devers.
No.
Don Duval.
Yes.
Mickey Fornes.
Mickey Fornes, no.
Carl Gandolfo. Not here. Okay, Gregory Gill.
Gill, yes.
Jason Haig.
Jason Haig, no.
Don Hudson.
Hudson, yes.
Dr. Isaacs.
Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Steve Kroll, no.
Andrew Knoll.
Andrew Knoll, no.
Jared Cutson.
Cutson, no.
William Masterton.
William Maston, yes.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
Elizabeth McGowan, no.
Mark Philippi.
Philippi, no.
Miriam Portoro.
Miriam Portoro, no.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener, yes.
Carla Simpson.
Carla Simpson, yes.
Christopher Smith.
Chris Smith, yes.
Chad Smith.
Chad Smith, no.
And Dave Violante.
Violante, yes.
Yes. So it passes.
We have 14 yes and 10 noes, but do we need a majority?
I have to use a calculator.
No, I know you can use it on the test now, too.
There was no extra charge.
How many yeses were there? So it'd be 45% if you use the main number.
While these guys are using high math here, if anybody wants to stand up and take a 2-minute break, it may take a while.
Yeah, let's take a recess for 5 minutes. We just need to consult a definition here.
My only concern is if you don't have a quorum now, if they don't come back.
Yeah, I think they will though, because we may finish
Yeah, I
close
think
to on
yeah,
time.
That's pretty good.
Yeah.
Yeah.
Because with 32, it would be 17.
So it doesn't pass.
It's going to pass.
It does pass.
Okay,
Did he give you the answer?
yeah, it passes.
But just so that you understand the backing
Yeah,
behind
no,
it for both of you.
I understand it now.
Do you believe you're supposed like?
All right, I want to get the meeting back on track here. So this motion that we just voted on passes. We were a little bit confused about the difference between a quorum and a vote. And to have a quorum, we have to count all the members' seats that are available. To do a vote, we take the majority of the voters present. So we have a quorum. We did get a majority vote, so this motion passes. You need a microphone there.
In my opinion, and I'm not a lawyer, this violates the general construction law of New York State. However, Ryan has, over many times, consulted with his own lawyers who say that the SEMSCO rules override the general construction law. I can't argue that. The only thing I can say is that the losing party here can, and I would recommend, hire a set of lawyers and challenge it in court. So we have a legal response once and for all. But in any event, when no one challenges it, then every time this comes up, we're going to go this way.
All right, well, we're going on the advice of counsel to this council, so thank you. Mr. Devers, next.
All right, so the second one is Austining, and the motion that was tabled was resolved to uphold the February 2023 determination of Westchester Regional Emergency Medical Services Council, which approved the Austining Volunteer Ambulance Corps application for expansion of ambulance service primary operating territory. Is there any discussion? Hearing none.
Scott Clark,
Scott Clark, yes.
Dr. Krupe,
Dr. Creepy, yes.
Mark Devers,
No.
Don Duval,
Yes.
Mickey Fornes,
Mickey Fornes, no.
Carl Gandolfo,
Carl Gandolfo, yes.
Gregory Gill, Jason Haig,
Jason Haig, no.
Don Hudson,
Hudson, yes.
Dr. Isaacs,
Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, no.
Andrew Knoll,
Andrew Knoll, no.
Jared Cutson,
Cutson, no.
William Masterton,
William Masterton, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, no.
Mark Philippi,
Philippi, no.
Marianne Portoro,
Marion Patoro, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Red Leonard, yes.
Carla Simpson,
Kyla Simpson, yes.
Christopher Smith,
Chris Smith, yes.
Chad Smith,
Chad Smith, no.
David Violante,
Violante, yes.
Greg Gill came back in.
Gregory Gill,
Gill, yes.
motion passes.
Motion passes. Well, that went much better than December. Huh? Yeah, could we ask Mr. Lewis to come back in?
I believe Mr. Lewis departed for the evening.
He departed the building.
He was packing his vehicle and got into it.
Oh, okay, all right. So a couple more things. Any other old business that people see? If not, we'll move on to new business. And the first item on new business is Rural EMS Task Force, or the Rural Ambulance Task Force. And I asked Mike Benamati if he could give us a short update on what's going on with the task force.
Thank you, Mr. Chairman. So my name is Michael Benanati. I'm the Vice Chair of the Rural Ambulance Services Task Force. And so we've been very busy over the last year. We continue to meet. We had the town hall meeting here in December with this group. Since then, we have held 4 additional town hall meetings virtually at a variety of times to make them more accessible to all of the rural EMS providers. We currently are working with the writer in order to keep the project on track. We're hoping for a completion by April 1st of 2024. We've been involved with several rural EMS initiatives and development of effective rural EMS solutions, and so we're progressing nicely along that. These discussions certainly have involved creative thinking, and we're very positive that they will provide a real forward initiative to rural EMS challenges. And there appears to be, outstanding positive momentum with our elected officials, for which we're most grateful, and we look forward to getting our report released. Thank you, Mr. Chairman.
What was your projection again as to when we might see the report?
Around April 1 of 2024.
My favorite day, April 1st.
So we'll make it the 2nd.
Okay. Credentialing is next, and I want to we heard earlier from Jason Winslow about the work of the credentialing group. There's a fair number of folks involved in that. They were meeting weekly, they're meeting every other week now, and there's 2 things that are in progress. One is they are conducting a survey of all of the REMSCO or program agencies as to what each REMSCO is doing for credentialing currently and what credentialing practices are in place in their regions, which they think will inform some good decision making about drafting proposals for new policy and or regulations. And then the second thing that they're doing is they identified 4 policy statements that affect or speak to credentialing, decredentialing, that sort of thing. And they have a group which started out with 4, I think it has 6 in it now, who over the next couple of weeks are going to take those policy statements and do 2 things. One, point out the conflicts between them and suggest what would be best when policy statements conflict with each other. And the second would be to answer the question as to whether or not all of those 4 policy statements could be combined into 1 or maybe 2 rather than existing on their own, since they clearly conflict with each other. So more to come on that. Paul Barbara is chairing that committee, and I usually get on to help him out because, as you might guess, it's somewhat contentious. So, which leads me to one of the biggest items on the agenda today, and the last item, and that is the performance standards. So we got from last summer 11 proposed performance standards that came from 4 committees. And this was a charge from the governor to this group to come up with performance standards that would affect agencies, program agencies, REMSCOs, the emergency departments, and 911 centers in New York State. And obviously, those tentacles don't necessarily reach to all those places. So I asked Mark Philippi, because he seems to have the patience of a saint, to put together a committee over the last couple months of last year to analyze the 11 statements and come back to us with some actual workable things. We posted those on Boardable. They went out with the EDCC documents. So you probably had a chance to look at them. In synopsis, the 4 that they gave to us were 1 on systems, and that basically would require agencies to report their staffing for the prior month by the 15th of each month and send those reports to the Bureau and to their REMSCO. And they also would report total requests for service for the prior month by the 15th of each month. So that is a performance or reporting standard under systems. The second one that they propose is a training and ed standard, which each service would be required to report an annual agency educational plan for their agency. The third was a safety performance standard, and that would require each agency to develop a safety committee that would track and trend safety issues, primarily injuries and crashes that occur. And the last one was a quality performance measure, which would require each agency to select 3 or more SEMSCO-approved quality metrics and implement those in their agency and report by the 15th of each month how they're progressing on those or how they're measuring them. So those are the 4 that we have in front of us. I would like to see not us adopt any one of those, but I would like us to pick 2 of them and then perhaps spend some time at the next SEMSCO meeting trying to refine how they're written, who they apply to, that sort of thing. And you have a pretty good document in front of you already from Mark Philippi's group. But Mark, do you want to say any more about the grueling process that you went through, how many lives were lost, et cetera?
Thank you, Mr. Chairman. I actually just want to thank the team. We had a large group of folks who volunteered to step forward in a very short timeline. We had 4 extremely dynamic team leads, and I want to thank them for all of their assistance with this and getting it together. Obviously, nowhere near the amount of work that went into Chief Beninati's team, but I want to think that what we've got together dovetails nicely with the work product of the sustainability tag, because I think each of these 4 have the potential to move the needle forward for EMS accountability as well as sustainability. There are a couple of these in particular, and one of the things that I've spoken of many times before is how we keep getting beaten over the head as a profession by things that are as arbitrary as response times. And response time is not a good metric of how well EMS does. I think some of these will move that perception forward and be able to give lots of folks, including our legislators and our executive branch, some numbers by which to gauge our effectiveness. So with that in mind, as the group deliberates which of these 2 they would like to select, I would suggest looking at these with an eye toward what is measurable, what is attainable, what is replicatable, and what is timely.
Thank you, and thank you for your work. I see this, I would like to pick 2 of these, which means 2 of them are not going to be picked now, but all of these things that came from the work of the committees have potential in the future to be good performance metrics. I think we need to select 2 of them that are workable for an agency with 5 members and workable for an agency with 5,000 members. And I don't know if anyone wants to comment on that or open the discussion. In my mind, I see the systems one about reporting calls and the quality one as being 2 that are near and dear to this body in the work that we're doing on sustainability. So I'll open the discussion with that.
Mr. Chair, is there any reason we can't pick all 4 of them? All 4 of them?
It's too big of a bite to start with.
Okay.
I said to Mark's committee when they first started that there is going to be kickback about this, and so we need to be slow and gentle as we proceed.
May I, Mr. Chair? Yes. So one other thing to keep in mind, this is not a situation that at the moment that the next step in this is done, that all of a sudden it goes into fruition and all of a sudden everyone has to, abide by it and everything else. These will be turned into regulation. So once this is done and the committee has worked on what they want into that regulation, we will then take it, turn it into the legalese and the components that come along with it, run it back past the group again, just to make sure that nothing changed in that direction, and when we had to change wording, a look at wording, and then go through the regular regulatory process. So it will go out for public comment period, it will come back, and then, be voted on as a final thing through this committee. So just wanted to give situational awareness on that one for anyone who turns and says, well, I heard starting tomorrow, all 4 of these are in effect. That's not the case either.
Mr. Chair, I completely agree with you that we should look at if we've got to pick 2, and I agree with Mr. Violante as well, that 4 would be awesome. But if we're tied to 2 for the time being, the systems one and the quality one, we know we do not have a healthy system, and part of that is we have limited data, and even in some of the counties, there's various metrics that aren't always the best. And honestly, our focus is patient care, and we definitely have a fractured quality component throughout the state. And truthfully, they're probably the 2 most important things we can start with.
Mr. Devers, if you're making that a motion, I would be more than happy to second it.
I will make a motion that we select the systems committee 1 and the quality metric.
Second. Second by the Chair of Innovations, who I think is in cahoots with the quality chair. Don Hudson, did you want to comment?
No, I think we should vote on those 2 motions, the motion.
All right. Since we're just fleshing this out, we don't need to do a roll call vote because these are not going to take effect in any way, shape, or form. So those in favor of choosing systems and quality, raise your hand. Any opposed? Same sign. Any abstentions? So that carries unanimously. So that gives us some work for May. Any other unfinished open business?
So you did see my mic light up before, but I didn't want to skew the vote. So now that that vote has been taken, we use the, I'm trying to craft this, I'll just say it. So we use the carrot and the stick model. The carrot is we want people to be invested in their systems and their people and fix things as they find them altruistically. That being said, if that doesn't work, what's the stick here for performance measures? So with responsibility has to come accountability. And I think that's also a missing piece of our system that has woefully never been addressed. And I realize regulation has been proposed to sort of address that and give teeth, is another anachronism that we use. But what do we do to an agency that says, I'm not giving you my data? And don't want that answer today because it shouldn't be a knee-jerk reaction, but we need to prepare for that because I would suggest we can all pick an agency that comes to mind and see if that's going to happen.
And I could not agree more with you, and I think those are things that we need to flesh out. So, our next meetings are scheduled for.
Chair, Mr. Chair,
Yes, Beth,
I'd like to bring one more piece of business.
go ahead.
Given the confusion we just have, I'd like to make a motion to change the bylaws to bring the council's bylaws to be in line with the Open Meetings Law, Section 102, and the General Construction Law, Section 41, which defines a quorum as a majority of the total membership of a public body, notwithstanding absences or vacancies, and for a motion or action, there must be an affirmative vote of a majority of the total membership of the body, not just an affirmative majority of the members present.
Do I hear a second?
Sure.
Second by Donnie Duval. Any discussion?
Just refresh my memory, what is the process for amending our bylaws?
I have to consult the bylaws on that, but I believe we have a bylaws committee that I was holding off on getting working until we had the ethics training, and we now know what things we need to change in the bylaws. Beth makes a good point. So there is a provision for making changes to them, but this group is going to look at the whole set and say what else needs to be adjusted there.
Yeah, and I agree, we desperately need to edit them. I just want to make sure the process is followed and correct.
Thank you, Mr. Chair. Carl Gandolfo. So not to belabor the point, and I know people are probably anxious to get out of here, and Dr. Langston and Mark, if you could just refresh the memory of me. I think that we covered this and we changed this in the proposed bylaws that we presented to the council in June of 2023, maybe prior to that. I have a copy that I was able to find in Boardable. As far as voting goes for this council, it's covered or it's addressed in Article 30. But just to get into the Section 3 on voting in our bylaws for the council, each member of the state council shall have one vote. Alternates may not hold office nor act in the capacity of an officer of the council, and that was something that was debated and added in, and other language was struck out. No proxy voting is authorized, and the affirmative vote of a majority of those members present shall be required to carry the motion of any item of state council business. And then it goes on to specify what a roll call vote is obviously necessary for. But we have addressed this, and I would refer the council and anybody else who's interested to just take a look in Boardable. If you can't find it, I'm sure Peter or somebody else on from the state would be able to help you find it. But it is there, and I think we proposed these. I can't remember if we voted on them, or if we passed them, or if we tabled them. So that's something we'd have to go back and look at the minutes of. But we did discuss this because this seems to come up often when we face votes up here, and I think that it would all help for us to just go back and look through the bylaws to address some of the issues that we may be continually seeing here. Thank you.
Yeah, and for those who haven't been around as long as your recollection goes back, they lingered for a really, really long time at DLA, finally came back with a bunch of recommendations, and so we have the current bylaws, the proposed changes, and the DLA recommendations. And then we also received templated bylaws for councils and committees from DLA that we're also comparing to what we currently have. So there's plenty of opportunity to fix those things now.
Our bylaws have no legal standing versus whatever the law might be. Okay, whether the law is as the open meeting law states or as the law as somehow or other SEMSCO has a special set of rules, which is what our lawyers claim. What, if I may digress, what is long overdue is the bylaws being updated. And this has been now at least 3 years that the bylaws have been in the hands of I point to the people in charge, and it has not been brought before this body. The body has a right, I'm not a member of the body, but the body has a right to demand that the changes of the bylaws be brought to the floor and discussed and then passed. And then the lawyers can come and say it's all illegal if they want. But that's not the way it works. The body has the right to demand that its chair bring the bylaws from whatever committee is working on it to the floor for discussion. This has not happened for at least 3 years. I'm done.
So any other discussion on this motion? If not, we'll call a vote. This doesn't need a
Does it
roll
have
call.
to sit on the table until the next meeting before a vote? Has to be published and then sit until the next meeting?
I think it takes several meetings to do that.
Well, for following Robert's rules, yeah, then it should be read at 3 consecutive meetings prior to a bylaw change taking place, right?
So does that, Mike, just a question, does that require a roll call then, if we're just passing a motion to propose this, and then it'd be 2 more times?
It goes on, it gets read at consecutive meetings before it gets voted on, and it can be discussed at consecutive meetings. So we won't vote on it, Beth, but we will read it again. Can you email that to us? Yeah, good. Any other?
Amend the bylaws at this meeting is out of order. The bylaws have not been read before the group, and they haven't been brought for discussion. And you have to do that 3 meetings ahead,
Right.
1, 2, 3.
This is what I just
And
said.
I also think she's talking about the current bylaws, though, not the bylaws you're referring to. She's referring to the current bylaws, not the bylaws that you're referring to. She's asking for an amendment.
Bylaws requires 3 meetings.
No, I agree with that.
Okay. So what are we?
Don, you have something to say?
Well, I am also not a lawyer, and it's possible this motion was out of order, but it's unfathomable to me that different sections of state law, I hear terms like general construction law, business law, public health law, that there would be a conflict in any of these laws. I just can't imagine that they wouldn't all say the same thing. And maybe it's like trying to tilt a windmill, but whatever we craft and wherever we go from here probably needs to somehow meet all of the existing laws in one place. Because that's the elephant that even ethics training couldn't solve. No discussion about which sections of state law are relevant and which aren't, and how they work. So maybe we should give the lawyers some homework and figure out which laws are relevant and how to reconcile different laws with different requirements from different sections of the entirety of the state rule book.
All right, so noted. Any other new business? If not, I'll,
Just, I can't help myself. Is it too much to ask that our bylaws as a public body be posted to the New York State Department of Health Bureau of EMS public SEMSCO page? Because I don't know what we're talking about. Is it the current set, the edited set, or the secret set that no one's allowed to see? What are we editing? I'm half serious, which also means I'm half joking, but what?
Right, so that would be my question as well. What is the motion on, and what are we looking to do? Are we looking to edit the current bylaws that are published? Are we looking to edit the proposed bylaws that were published? If you could just clarify, Ms. McCowan.
I am looking to edit the bylaws that I believe are current, which were last amended on March 27th, 2002, and became effective March 27th, 2002, as I believe that is the current set of bylaws that we are operating under, as no other set of bylaws has been voted on, although they have been proposed.
Although I have a set in front of me that's December 12th, 2007, as having been.
And
Okay,
just
I
to be
change it
clear,
to the 2007 bylaws.
And I have another set that's December 24th, 2014.
I also see that third set of bylaws. You get my point?
So maybe we should hire a bylaw hunter.
And that just goes to the point, because when I joined the council, I asked Dr. McAvoy for the most current set of bylaws and was sent the 2007 version. I think any council that I sit on, or I have always asked for the bylaws in order to understand. And being a fairly new member of council, I was given something that was 3 revisions ago.
And to that point, as the person who kind of started this whole mess 4 years ago, the version that I was dealing with was the 2014 version, because that's the version I was given by the then executive secretary before Ms. Ozga took over that position. So that's what I've been working on. And if you look at the footnote, I believe, on the bottom of the version that is in review on Boardable, in fairness to everyone here, it's been posted in Boardable for months. I'm sorry if folks are having trouble finding it, but it has been there, and it's been repeated by the chair that it is on Boardable. And that is, anybody want to correct me if I'm wrong, but that's the working copy that Mr. Gandolfo, Dr. Langsam, and myself have been working on, and that was the circa 14 version.
So according to the official records of the Division of Legal Affairs on the adoption of bylaws, the current copy was adopted on December 12, 2007. There was proposed amendments put forth on December 24th, 2014. I'm not sure why it happened on Christmas Eve, but that's when it happened. Those were not adopted. They are not effective. So the most current effective bylaws are December 12th, 2007.
So can those be posted to the Bureau website?
Yes.
All right.
Microphone. The last effective date was December 12th, 2007. After that, there's a blank space waiting for approval, which never happened. Because there were proposals made, and then somehow or other it ended up by lawyers.
That reiterates what I have on file with the Division of Legal Affairs as the official copy.
So let's get those
12,
posted,
2007.
and that will answer your questions about what the current copy is, and that is what we will use to make the amendments.
Mr. DeZuri, I believe that the 2007 bylaws doesn't have the section you showed me that we discussed a little earlier.
That was the same copy.
I'd like to make a suggestion. I know we have a motion on the floor. I would like to suggest, though, this is slightly preliminary a conversation until we uncover a couple of pieces of fact and make them certain and agreeable to everybody. Number one, what are the current bylaws? I think it'd be very easy, and I am not volunteering to do it, but to consult the minutes from 2014 and 15 and confirm whether they were voted on or not, and establish that the 2007 bylaws are indeed the 2007 bylaws. I think, secondly, it would behoove us to have Division of Legal Affairs explain to us, maybe in a paragraph, why they ruled today the way they ruled on what they believe the predominant decision is on a quorum for a vote. Because we're tossing, a couple people here have tossed back and forth general construction law versus Department of Health policy versus bylaws. What is the basis of the decision that they have made, that they recommended to us for the vote today? And I think that sets us up to be in a position to discuss, number one, bigger bylaws change project, but number two, and look, Mark put a lot of effort into this, and I was on that committee, and I know we never finished the job, but a lot of debate went back and forth. But after that debate went back and forth, we recognized we had not consulted the model bylaws that the Department of Health had thought we didn't even know they existed. So there's a model set of bylaws, there's Mark's draft set of bylaws. We can have that discussion, but also more directly on the point that Beth is making. If we know what the bylaws are, we understand why Division of Legal Affairs decided the way they did today, then we can discuss the proposal that you're making, being well-informed as to the implications of, whatever the vote would be on that. So to the instant moment, since there is ostensibly a bylaws committee that is reviewing the bylaws, do we take the motion made and seconded that is currently on the floor, move that to committee, so that, and force the issue that it comes back to this body for reading?
Point of order. Point of order. We call the vote. Yeah.
Well, I don't think we call a vote. I think this gets read at subsequent meetings and then vote. So we can't vote on it now.
The bylaws come before,
Yeah.
and then it
Right.
goes three more sessions after that.
Can't
And
even
I don't
say.
think, correct me if I'm wrong, that we've ever had the lawyers actually give a written opinion on this matter of voting. What has happened is each time this issue has come up, the director has walked out of the room, spoken to the lawyers, and come back and given us what they've said. And I'm not denying that that's what they said, but that's what they said. But I don't think there's an official.
This time I didn't have to walk out of the room. There's three of them who are sitting directly behind you. It's much more convenient this time. And I do believe that they reference, and they are lawyers. That's true. So thank you for the clarification. Three of them. So, in this case, and I think they were, in this case, and they're referencing in their legal advice is referencing the bylaws as they were approved, I guess we would say in 2007, based on record of effective date, that this council has had in place. And by the way, I don't see a reason in not being able to post those up on the website or anything else. Good suggestion. Thank you for everyone. To be able to move forward on that one. So just on where that came from, that recommendation and things of that nature. In regards to, the bylaws and discussions and recommendations that you kind of put forth to here, there were recommendations that were made related to those bylaws that were brought back to this bylaw committee to work on, to say, hey, here's your legal advice from your legal counsel for the Department of Health related to the bylaws that you proposed. That is not sitting with the Bureau, it's not sitting with the Division of Legal Affairs, it's not sitting with anybody else, except for the council to determine what they want to do with those recommendations for those bylaws.
But did those recommendations ever come back in 2014?
They came back last year. Yes.
I can't speak to 2014. That was before my time.
True, and I'm not blaming you. I'm just thinking maybe they were in the same office as the original blood and blood products regulation changes.
No, the 2014 ones did come back with commentary from DLA in 2023.
So the council never completed the approval process.
So let me close on a positive note. The ethics training in person the other night was something we need to do regularly. And I wouldn't even call it ethics, or it needs to be more than that, because that's undercutting the work that thank you again, as I was somewhat reprimanded for thanking them too many times as we were beating them up the other night. But sorely needed, just as a civics lesson, if not a procedural and ethics lesson.
I would agree with him as well.
All right.
Dr. McAvoy, motion to adjourn.
Second.
Second.
Thank you all for everything that you do.